Namaskar and good evening, everyone. A warm welcome on the second day of Udaipur Multidisciplinary Cancer Summit 2026. With immense pleasure, I would like to invite Dr. Ankit Agarwal, Consultant Medical Oncologist at Gitanjali Hospital, Udaipur, for the welcome and introductory note and to take the proceeding forward. Over to you, sir.
Thank you all. Thank you for joining. And we are on the second day of our webinar. And I think without wasting further time, I'll request Dr. Manoj Mahajan to go ahead with his next talk regarding the updates in ASCO that were recently presented in 2026. Dr. Manoj is a senior medical oncologist, and he's running his own cancer care clinic and a daycare chemotherapy center at Udaipur. So, I welcome Dr. Manoj sir for your talk. Over to you, sir.
Hello. Hello. Am I audible?
Yes,
Yes,
sir.
sir.
Yes. So, shall we start?
Definitely, sir.
Pooja, can you run the slide?
Sir, can you see the slides?
Slide. Yes, yes.
Okay.
Okay. So, first of all, I would like to thank Dr. Ankit for giving the opportunity and conducting a session on. It's like my topics were quite interesting. So I have limited time, so I'll flip. I'll start with the adjuvant pembrolizumab in a setting where like SCC post complete radiological response and after surgical resection. So local therapy can be surgical resection or oblique local ablation. So next slide. So the concept is like continuing the adjuvant therapy after completing your local therapy. Just what we are following nowadays in lung cancer. So this is a apparently the key takeaway are this is a negative trial which did not meet the RFS, OS, and still there is unmet need. We do need to have the more data in the adjuvant setting for the SCC. So I'll quickly go through this first detail. Next. So background is like 5-year survival rate with the surgical resection are to the tune of like 3/4 patient.
Sir, we cannot hear you. Dr. Manoj Mahajan.
Manoj sir, you're not audible.
Team, can someone call?
I think there is some sound.
Yeah, technical,
Yes,
technical.
yes. I
Sir,
got
sir,
logged
we'll
out.
call.
I
We'll
got
call.
logged out automatically.
We'll call, sir.
Yes, ma'am. Pooja ma'am is calling.
Okay.
Actually, there is some technical glitch. I also got logged out automatically twice.
No, sir, happens when there is a connectivity issue. Otherwise, we are
Okay.
there in the meeting.
Oh, okay, okay. All right.
Actually, I am in full Wi-Fi zone.
Sir, you can go ahead. We were not able to hear you. Now move next slide.
Okay. Therapy in patients with after the local therapy. Next slide. Next slide. So this was it.
So you are not audible.
Previous slide. I'm audible now. Hello.
Audible, sir. Just now you're audible now.
Yes, I think there is some technical glitch. I'm like automatically logged out of the presentation.
It happened with
Almost
me
this.
also. I think
Yes.
now I think we can go ahead. You can carry on with your talk, sir, please.
So the key eligibility criteria for these were like CC, complete radiological response after surgical resection, ECOG PS01 and childhood liver class A. So adjuvant therapy was placebo versus
Manoj sir, kindly check your internet connectivity.
I think he automatically got logged out. I think.
I am on full Wi-Fi. Full Wi-Fi.
Tech support, kindly help. Sir, you can go ahead.
Hello.
Yes, sir, we can hear you.
Okay. So next slide. So this is the study design where adjuvant pembro versus placebo after complete resection or local ablation. So both the groups are quite well balanced in terms of geographic location, ECOG performance state, viral etiology, underlying viral etiology, alpha fetoprotein levels, and childhood scores and other high risk factors. Next slide. So from the KM curves for the recurrence-free survival, we can see there is hardly any difference. So giving adjuvant immunotherapy does this trial has clearly shown that adjuvant pembro has no role in this situation as of now for RFS as well as OS. That is will be seen in the next slide. So 48 months rate are almost equal, and all the substratification, including the underlying viral etiology to other high risk features, including child folk score, prior local therapy, all are uh, like crossing the unity, and so there is no clear cut favorable side. And this trial has probably this is a negative. This is a negative trial which has not shown any effective intervention of adjuvant immunotherapy. Next slide. Again, for the same, it's the OS curve. Curves are separating late and again merging each other after around 3 to 4, around 3 years. Next slide. Hazard ratio is 1.08. Distant metastasis DMFS. Again, hazard ratio is reaching to unity 0.98. There is no separation of the curve. Next slide. Adverse event profiles are higher in pembrolizumab. Obviously, that is expected versus the placebo. Next slide. So, next slide. These are congruent with our experience with the immunotherapy drugs. So, to conclude, this trial has conclusively shown this adjuvant pembrolizumab does not demonstrate any improvement in the RFS versus OS or any DMFS. Next slide. So we'll come to the next abstract, like Majestic 9. It's a teclistamab monotherapy versus investigator choice of POM board DEXA PVD in patient with the relapse refractory multiple myeloma. Next slide. So what is interesting in this trial is there are like with the conventional molecules, the standard of care has been established and Majestic 9 has improved over and above the conventional standards. So we'll go through what are the significant advantages this trial has shown over the conventional treatment. Next slide. So what is the context for this? As like there are later lines of therapy, there is chances of recurrence. The patients who did not have a deeper or durable responses have recurrences. So in other trial like Mastec 1, TechWiley has improved the overall response rates. So coming to this trial, which is monotherapy against the PVD regimen in second line plus RRMM. Next slide. So this is the study design, which shows it's a 1:1 randomization of almost 600 patients, 1 to 3 prior lines of therapy, including anti-CD38 monoclonal antibody and lenalidomide, ECOG PS01. So it randomized in tech versus PVD oblique KD, and primary response endpoint is PFS. Key secondary endpoints are CR rates, OS, and the 28-day cycle. The first cycle is challenging one, day 1, day 3, day 5 dosing, then every 7th day till day 19, and then subsequently day 1, day 8, day 15, day 22 cycles. And after 7th cycle, it can be given day from cycle 3 to cycle 6, it's day 1 and day 15, and from 7th cycle onward is once a week regimen. Next slide. So if you look at the disease characteristic, so elderly patient subgroup are almost more than 30, one-third patients are elderly subgroup, which is quite a in clinical practice, we see many elderly patients in this age group. Then the stage 3 patients, nearly 15% in each arm, patients are in stage 3. Soft tissue plasmacytoma. This is again one of the rarity where we have nearly 20% of the patients in each arm, quite well advanced stage or high risk feature, uh, RRMM. High risk cytogenetics, almost one-third patient has high risk cytogenetics. Next slide. Median range of one line or prior lines, like after one prior line, only 20% of the patients, two prior lines, almost 44%, and three prior lines, almost one-third patients. So we can understand the subset this trial has taken, subjects have taken which are heavily pretreated. Even the prior transplant patients are autologous post-transplant, almost 50% patients are post-transplant. And at least if you say lenalidomide, almost 85% patients have already received lenalidomide refractory, and anti-CD38, almost 85% patients. So these patients are double refractory. So we can understand how much heavily treated this subset or these patients are. Next slide. So patient disposal and exposure. So how many patients are still continuing with the TechValley? Nearly 65% versus PVD only 25%. Quite a stark difference. Reason for discontinuation are around 10% patients have adverse events and discontinuation. In PVD, nearly 13% of the patients discontinue. And then progressive disease in 20% of the patients with the TechValley. More than half of patients in PVD fail the treatment. Next slide. So the primary endpoint of PFS at the end of 1.5 years, it's 69 or 70% versus 26%. It's a huge difference with hazard ratio of 0.29, especially in this heavily pretreated subgroup. So that itself is a remarkable in terms of the results, having a such narrow confidence interval plus very high, very low hazard ratio. Next slide. So on PFS benefit, this TechValley has succeeded to meet the primary endpoint. And if we look at the substratification factors, where patients who have lane refractory, anti-CD38 refractory, double refractory, all baseline characteristic, number of lines, advanced stage, or higher cytogenetics group, all the subset are favoring the tech group and tech arm, and all of them having the hazard ratio in the ranging from 0.2 to 0.4. So that itself is again a remarkable finding. So all the subgroup, even all these high risk features favor a treatment with the teclistamab. Next cycle. Next slide. So coming to the overall response rate rates are much higher, 85% versus 54%. Median range time for the first response is it's similar in both the arms. Medium time to first CR, again 5.8 and 5.6, similar. So now come the game changer, like what is the duration of the response? Median duration of response in months with PVD is around 13 months. But in TechValley group, it has not reached. That itself is remarkable. And estimated 18-month duration of response is nearly 80% versus 40%, half of it. So in all parameters, next slide.
Sir, sorry to interrupt you. Sir, please conclude the session in next 1 or 2 minutes.
Yeah. So Majestic MR, this is MRD negativity. Again, for available time set, it's almost nearly 90% versus half of the patients in the PVD arm. Next slide. OS, again, this trial has shown the OS benefit. And if you look at the safety profiles, overall safety profile is quite well manageable. The common side effects, CRS, ICANS, are mostly grade 1 and grade 2, not very high grade 3. Next slide. The one worrisome side effect with the TechValley is the infections and hypoglycemia, which is common. So the mortality, or there is grade 5 infections, are almost in 5.5% of the patients. So that is again very high number, and most of them are URTI, pneumonia, COVID-19, nasopharyngitis, UTI. Next slide. So over a period of time, this goes on decreasing. Next slide. Next slide. So to conclude this trial, there is superior PFS, superior overall response rate. The side effects mainly are CRS and ICANS, which are mostly grade 1. Infections are common, but usually the incidence decreases after 6 months. And we should monitor with the prophylaxis monitoring and IGRT or immunoglobulin replacement therapy in most of the patients. One more abstract is present, but I think we can discuss in the panel.
Yes.
Yeah.
So thank you, sir. Thank you so much. So for the next, I would like to go for the panel discussion for this on the above abstracts, and I would like to invite the moderator, Dr. Tarachand Gupta, Senior Consultant Head and in charge of Geriatric Oncology, Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur, and would request as a panelist to join Dr. Ankit Agarwal, sir, Dr. Manoj Mahajan, sir, Dr. Pulkit Nag, sir is already there, and Dr. Devesh Parashar as a panelist. So kindly. And Dr. Twarachan, over to you, sir.
Tarajan sir, you're not audible.
Hello. Now? Hello?
Sir, unmute yourself.
Tarajan sir, you're muted. Yes.
Yes. Now I'm audible.
Yes.
So, So we will discuss 3 studies, but as I am not practicing so much hematology, so we will discuss only 2 studies. And out of these 2 studies, only the one study is very important. So that's why we will discuss the first study first, and then second study, just a light on, will throw the light on. So this is the Emerald 3 study. So this is basically a stride plus lenvatinib combined with TACE, or a stride plus TACE, or TACE alone. This was the study. So first challenge is that this is a typical case. You can say that hypothetical case. It is a 58-year-old male with a hepatitis B related SCC, intermediate stage, large bile over disease with BCLC-B. He is not a transplant candidate, no macrovascular invasion, no extra hepatic spread, childhood A, ECOG PS 0, treatment naive, embolization eligible. So now we should start our discussion. So Manoj boss, starting from you. So what do you think? That was the case only, and we will discuss. Point Kangai was it? बनाए थे यार. एक मिनट यार. रुको ये ना. Something is. Let's see. चलो इसमें से ले लेते हैं. That is, I think some color contrast का चक्कर पड़ रहा होगा. Yeah. Is TACE becoming obsolete or still a modality of treatment in hepatocellular carcinoma? Manoj boss.
No, I think TACE is not obsolete, but I think sorry. So there are certain patients who are fit, who does not have like localized disease. TACE definitely gives some additional margin in along with the stride regimen. So I would vouch for like going into the results, though they have not compared arm A versus arm B, but TACE alone with the TACE alone and combination with TACE plus stride, it gives definitely an edge for patients like this.
Ankit, in on which stage you will use TACE alone, or that means the along with the stride plus TACE? Can you clarify in stage wise manner?
I think now TACE patient who are actual candidates for TACE, we rarely see in our clinical practice, especially in the Indian scenario. BCLC-A, I think, who have localized disease, BCLC-A less than 3 centimeters. I think these are the candidates who do not have portal vein thrombus. These are the candidates which I think are good candidates for TACE. Otherwise, we don't usually see patients who are eligible for TACE in our clinical practice.
So, Pulkit, we have the opinion of Ankit and Manoj boss. So, Ankit is saying that at less than 3 centimeter, at less than 3 centimeter, what will you prefer, like resection or TACE or TACE plus stride or anything? Pulkit, are you there, Pulkit? Meanwhile, Dr. Devish?
Hello, yes, sir. Yes, sir. I am
Yeah.
hematologist actually, sir. I'm a hematologist actually, so I
Okay.
don't have any idea.
So, no problem. We will take opinion of like thrombocyte opinion if SCC and CLD, and we will take. So we should go in there or not. So Pulkit is there or not? No.
पुलकित सर का कनेक्शन ड्रॉप हो गया था. ही इज जॉइनिंग.
सर गुड इवनिंग सर.
अरे गुड इवनिंग पुलकित यार, कहाँ घूम रहे हो यार तुम? है ना यार, इतना फंस गया केस फंस गया पूरा का पूरा हमारा यार, है ना
सर. आपके बिल्डिंग के सामने से कार निकाल रहा हूँ.
अरे तो तू यहीं रुक जाता, बिल्डिंग पे ही रुक जाता यार. ये केस फंस गया और तू निकल के आ गए. तो तू ये बता मेरे को.
सर अपॉलॉजीज.
नहीं कोई बात नहीं. अब ये बताओ मनोज बॉस ऑलरेडी थ्रोन लाइट ऑन एमराल्ड 3 and that less than 3 centimeter hepatocellular carcinoma, will you go with the TACE resection or stride plus TACE or TACE plus lenvatinib? What do you prefer? What will you prefer?
Sir, how is the performance status of the patient?
Perfect. He is fit as us, as like us.
That means
okay. And what is the child cox scoring, sir?
Because he is a ECOG PS 0, CPS score A, no macrovascular invasion, no extrahepatic spread.
Sir, I'll first take the opinion of a surgeon, a gastro surgeon. If he is okay with the surgery, that's will be my first option. Otherwise, TACE will be the best option for me, sir.
Okay, okay. So, good weekend. There is a
Sir,
difference
sorry,
of opinion.
I missed the
All.
I missed the trial, sir. I'm sorry, I was driving, so I was
That
not
is the
able to hear the trial.
that is Emerald 3. That is in your finger, na? Emerald 3 on your
Yeah, yes, sir.
yeah. That is in your ring finger over the ring. Emerald. Okay. See.
Yes, sir. Yes, sir.
Emerald 5 है उनका.
Manoj was who should avoid therapy immunotherapy.
Hello. Yes.
Yes,
So,
yes, Manoj was.
patients who are having like childhood C, B and C onwards, plus patient who have extrahepatic disease should avoid the triple therapy.
Okay. So, Ankit, as we know that the Emerald 3 was positive for the PFS and OS is not there. So, does this affect your practice or yes, still no, we don't wait for the PFS and we don't wait for the OS. We'll go for them. And the PFS maturity is only 64%.
I think I would have been more confident in the Emerald 3 if there was only a stride arm with no taste in that. That would have I think I would have been more comfortable. But going ahead with stride with taste looks good, but I would want to wait for the OS data to mature and then confirm whether adding stride to taste is a good enough regimen or not.
Yeah, and Pulkit, there was another trial that was the launch trial where the taste was combined with the lenvatinib. And at that time,
Okay.
the OS was also 17 months, and that population was the, I think, BCLC-C in that population. That was metastatic setting was taken. So, how
sir.
do you interpret in these two trials and where it is fit? I will give Emerald 3 here.
Yes, sir.
And that is that launch only, or here is the systemic therapy only and stage. So we should Emerald 3 now in
Yes.
one glance.
Sir, first of all, the launch trial has combined TACE plus lenvatinib. Am I correct, sir?
Right.
Yeah, in BCLC 3, C.
Yes, that was because in metastatic setting it was there.
Sir, I already have one patient on this in ESIC, and the patient till now in last 3 months has responded pretty fine, sir.
Okay. So where will you go for the Emerald 3? Where will you use launch or where will you go for the systemic therapy only?
Emerald 3 is, sir, a single 3 centimeter lesion scenario which you have given me. Correct, sir?
Yeah, no. That was the only hypothetical from the Ankit side. The case is only a large bilobar disease intermediate stage, BCLCB,
Sir, I missed
not a transplant
sir, I'm
candidate.
sorry. I missed the Emerald 3 trial, sir. So can you just give me a highlight in one liner, sir? What was that exactly?
That trial
I just missed it,
compared with that trial compared the stride plus TACE, stride plus lenvatinib plus TACE, or TACE alone. So there was a PFS benefit and OS was not there. 64% PFS maturity was there.
I'll stick to TACE alone, sir. I'll still wait for an OS data to mature for Strive or plus TACE to use together, sir.
So let's see how the Emerald 3 performed. So these were the three arms, and pathological. These were the trial criteria where the CPS score A, performance status good. Pathologically or radiologically confirmed SCC, not curable but embolization amenable. No extrahepatic disease, exclude VP3, VP4 portal invasion because TACE is not possible in these cases. No prior systemic therapy. Endpoint were the primary PFS, arm A versus C. Key secondary endpoints, overall survival, arm A versus C. PFS and OS, arm B versus C, tested in the fixed hierarchy. Other were the overall response rate, disease control rate, duration of response, time to progression, PFS2, patient-related outcomes, and safety. So what was the data actually shows that there was a median PFS was 13 versus 9.8 month in the RA primary comparison with a hazard ratio versus RMC hazard ratio 0.70 with a significant P value and hazard ratio 0.84 for the interim OS was there. That was nearly a -1, crossing the point boundary of the 0.8. And another that for the RMB versus RMC, it was 12.9 versus 8.1 month, hazard ratio 0.71. With the hazard ratio for the OS, it was hazard ratio 0.70. That means stride plus stays versus RMC. So those are people are avoiding the toxicity of line water along with that. Or we can say that the patient is having hypertension and other contraindication. So that was the saver. So bottom line, PFS benefit is real and significant for the triple regimen. OS is trending favorably but not yet mature or significant. So for the test absolutely becoming obsolete or not, absolute 12-month PFS gain was 56.2% versus 42.9% with the triplet therapy. Overall response rate nearly doubled with stride plus TACE versus TACE alone. Doublet stride plus TACE shows the largest OS hazard reduction seen yet and 20 plus year without a positive phase 3 combination in mammalization. And this is the first one after the 20 years. So reason for the question, primary comparison OS A versus C is not yet significant. Grade 3 or more adverse events nearly triple with triple therapy. Immune-mediated adverse events in 56% of triple therapy patients versus 5.9% with TACE alone. So significant difference in the toxicities. BCLC-A early low burden subgroup showed hazard ratio of 1, no PFS benefit at all via the Emerald 3. So be cautious while we are using Emerald 3 for the BCLC-A. So if we go with the statistically versus clinically significance, that PFS arm A versus C, hazard ratio 0.70, OS arm A versus C, hazard ratio 0.80, PFS arm B versus C, descriptor only, and this is the rate. Now, is a PFS benefit sufficient to change guidelines or must we wait for the mature OS? After so much discussion, now we are again, we have moved the table now. So please, Ankit, starting from you. Is the PFS benefit sufficient to change guidelines or must we wait for the mature OS? Yes, Ankit.
Okay, although PFS data looks very good, hazard ratio being 0.7, 30% reduction, but still we would love to have a good mature OS data so that we can change our clinical practice.
So PFS maturity is 60%, and is that enough to trust the curve shape? Are any surrogate endpoint ever enough in a disease where post-progression therapy heavily confounded OS? And 43% of triple arm patients versus 70% of TACE alone patients went on to receive subsequent anti-cancer therapy. How does that affect your reading of OS? Manoj boss. So 43% of triple arm patient versus 70% of TACE alone patients went on to receive the subsequent anti-cancer therapy.
And went on to receive
subsequent anti-cancer therapy, second line. After the progression.
So most of the patient required second line therapy with the TACE, and that is expected. Like you are giving a modality which is not a systemic, it's a local therapy we are giving. So definitely most of the patients will require a subsequent anti-cancer therapy.
So what will it will affect the OS in 43% of the patients who have progressed on Emerald 3?
That will be very difficult to say because
you are using stride only initially. That is the first line dominant line.
No, 2-3 things. I feel the trial has few policies in terms of design. First, TACE cannot be TACE is a local therapy. Local therapy versus you cannot compare with the systemic therapy.
Yeah.
So, like the arm, which is the weakest arm, they have considered as one arm which is the only local therapy versus local therapy plus systemic therapy. So there should be some
Right.
systemic therapy versus systemic therapy and local intervention. So that would have been the better situation, and they have not compared the arm A versus arm B. Uh, I don't know the intention, but they have deliberately added that even the endpoints have defined by arm A versus arm C and arm B versus arm C, where arm A and arm B are almost having similar results. So adding lenvatinib does not make any sense to the local therapy and stride. So stride is a standard of care. The question is, do we need to combine this local therapy? So yes, we have the answer, like arm B versus arm C. We have better results. Arm A and arm B almost same. Adding lenvatinib will not add anything else. So there won't be any additional benefit.
Yes, correct. Their taste alone is only the local therapy, and you are not targeting systematically. So it is nearly a placebo type effect other than taste. If you are if you are comparing with the systemic therapy plus local therapy, both. So now, who
Sir,
will take this
sorry.
slide?
Sir, sorry to interrupt you, sir. Please conclude the session in 2 minutes, 2-3 minutes.
Okay, ये तो पहले खत्म हो गया रे. चलो, who will take this slide among the panelists? Sequencing dilemma.
All dilemma questions.
IO before test or immediately after, continuing immunotherapy throughout the repeat test or the repeat cycle or hold, wait for full recovery from post-embolization syndrome before resuming IO. Is the trial schedule evidence or convenient extrapolation from unresectable disease IO regimen?
Trial has included first dose of stride, and then subsequently they have given the test.
Okay. So boss will go with the trial schema only. And any deviation? Ankit or Pulkit, any deviation?
I totally agree with Dr. Manoj sir.
Yeah, same this side.
Post-embolization syndrome is how long we have to wait before starting again. Probably stride is a single dosing of and then go ahead with the test. But after
Actually, one proposed mechanism was there that the taste can produce the necrosis, then there will be angiogenic signals will be there, and those will be picked up by the lenvatinib, and then that pro-antigen growth tumor may be caught by these two therapies, and then immunotherapy may work. But still, trial schema is there, so we have the evidence, and we cannot go with the assumption base only. So this is another point where the BCLC-A stride regimen failed here. So we cannot overtreat the patient of the BCLC-A. Yes, BCLC-B and BCLC-C are the good candidate for the Emerald 3. And this was the PMJ Yojana Chiranjeevi Bhamasha, where you can use only face plus lenvatinib if it is there. So forget the Emerald 3 and others. And this was the Keynote 937, that was a negative adjuvant trial, and there was no benefit. So there is the only one question I have for this. Why did adjuvant IO fails here but succeed with test? And I think this will be the hypothetical only. Yes, because of after the results it is there. So we will discuss. So please tell me, and then we will close the session. Pulkit, why did adjuvant IO fails here? But succeed with this. Anyone? So let's have a discussion. This was the in Emerald 3 positive PFS. What was the hypothesis which could I extract from different articles and sources that macroscopic measurable disease left in the liver at randomization. So IO combined with the local-regional debulking antigen release events, triplet adds anti-angiogenic synergy. Tumor antigen release from embolization may prime immune response. And for the negative one, that complete radiological response, no measurable disease or antigen source at randomization. Monotherapy IO with no anti-angiogenic or local regional partner. Micrometastasis disease may be immunologically cold without an inflammatory trigger and consistent with IMBRAV 050 etiology plus bevacizumab, also failing to show sustained adjuvant benefit. But yes, this is a hypothesis because same time, pembrolizumab is positive in the keynote 564 for the RCC.
So this also answer the one question, like one like hypothesis that local therapy in SCC is more effective whenever it is like if we are able to come eradicate it completely.
Yes, well, definitely. Why we people are already practicing this type of the clinical scenarios where sometimes we send for the test, and even from the sorafenib era, we are doing that. Yes, it started sorafenib, test and sorafenib, and now it is lenvatinib and IOs. So whenever there we have a bad type of tumor and we found any opportunity, so or we have some greed to take the benefit that patient can survive more anyhow. So we use these types, sometimes surgery, sometimes RT, sometimes SVRT, and even in kidney we have seen the cytoreductive nephrectomy, debulking surgery. Even head and necks are also having oligometastatic concept also. So in bad tumors, usually these concepts are tried always. So thank you, panelists.
Thank you, sir.
Hazard ratio was
Thank
2.14
you.
in here in the pembrolizumab, right? Thank you,
Never
panelists,
seen,
and it was a wonderful discussion.
never seen in other trials.
So that's why.
Thank you,
So,
sir.
Malad, it is double harmful. So, PAP should be in a minus. It should be in minus. They will pay.
Thank you, sir. Thank you,
So,
Dr. Tarajan, and all the panelists for the
Thank you.
excellent moderation. So we move forward further for a session which is sponsored by Titus. And for this, I would like to invite Dr. Devesh Parashar, Associate Professor, Department of Clinical Hematology, FLS Medical College and Hospital, Jaipur, for the talk on treatment sequencing in AML, the evolving role of venetoclax. Over to you, sir, for your talk.
Am I audible?
Yes, sir.
My slides are visible?
Sir, it's coming.
Yeah.
Yeah, it's visible. Just make it full screen.
Yeah. So, good evening, everyone. My slides are visible or not?
Yes,
Yeah.
sir, it's
Now,
visible.
these
It's
are
visible.
visible. So, good evening, everyone. This is Dr. Devesh Parash. I'm working in SMS, the hematology department. So today's my topic for talk is the evolving role of venetoclax in AML patient. We are treating AML patients with 7+3 chemotherapy since last very few years. With in last 8 to 10 years, there is a evolution of some new therapies, and that changed the paradigm of this AML treatment. So AML incidence, as we know, increased with the age. 7 decade of life is the commonest part, commonest time of the life when the previous traditionally the AML patients are treated with intensive chemotherapy, but we intensive chemotherapy, but however older patients or patient unfit for intensive chemotherapy has very few options, and this leads to increased toxicity and mortality of these patients. So risk stratification of ELN 2022, it divides the risk stratification of AML is favorable, intermediate, and adverse risk factors. Some the favorable, we have given we give usually some intensive chemo who are eligible, followed by high tech, intermediate, and adverse. We will go for the bone marrow transplant usually. But the patient who are ineligible for intensive chemotherapy, we have few options. So now the ELN 2024 risk stratification for adults has been changed. The patients who are receiving less intensive therapies, the adverse is only mutated TP53 mutation. We are favorable risk when we have some targeted mutation. If we have, then this comes under the favorable risk stratification, intermediate other cytogenetics, and other molecular abnormalities. So then AML, there is the iceberg is there. There is visible disease, and hidden resistance is there. So leukemic stem cells are present in resting phase. We kill the bulk AML cells by some standard chemotherapy, but these leukemic stem cells are not killed, and these ultimately lead to relapse of the disease. So the BCL2 overexpression of these leukemic cells leads to drug resistance process and make them fundamentally impervious to anti-proliferative agents. So, as we know, AML treatment timeline is since 1973. We are treating AML with 7+3 chemotherapy. This is standard chemotherapy, and some people give HIDEC or IDEC or low dose RAC. In 1977, first bone marrow transplant has been done, and after that, 20 years, there is nothing new in AML treatment. The AML treatment no therapeutic advancement in last 20 years, and in 2017 there is some targeted molecules came into the game. Those are midostaurin, GO, CPX351, and inacidanib. In 2018, venetoclax came into the game, and gilteritinib for relapsed refractory FLT3 positive AML, plastazib, and ivosidenib for IDH1 mutant patient. So the discovery and the development of venetoclax is a very new and significantly impacted the treatment landscape in the AML. It is in BCL2 inhibitor, anti-apoptotic protein. BCL2 is anti-apoptotic protein and frequently overexpressed in the AML cells, and that promoting their survival and contributing to chemotherapy resistant. The synergistic activity of venetoclax with hypomethylating agents or some low dose RAC demonstrated in clinical and preclinical and clinical studies, leading to approval of the venetoclax in combination of these agents. So mechanism of action of the venetoclax is the venetoclax binds BCL2. It attaches to BH3 binding groove of the BCL2. It displaces the BH3 only protein, and that leads to activation of the BACs and BAC genes, and ultimately lead to cytochrome C release from the cell and caspase activation followed by apoptosis. So venetoclax plus hypomethylating agent. The step one is sensitization. The venetoclax isolates the target and it frees the back and the back's protein, and that lead to it lead to priming of the cell to the death. And the external push that is required, and that is done by some HMA hypomethylating agent like azacitidine and the decitabine or low dose RAC. So monotherapy creates vulnerability to the cell, and the combination leads to the treatment of the disease. The venetoclax is a foundation. It's not a standalone weapon. So the historical baseline of AML treatment is previously we are just carpet bombing we do, and there is 7+3 chemotherapy, and it leads to high collateral damage, or it eliminates the bulk set, but it leaves the some leukemic stem cells intact. The current paradigm of AML treatment is target foundation. So venetoclax and some smart missiles are there, next generation combination that are targeted for these leukemic cells. The ultimate goal is no longer just managing the bulk disease, it's the mechanical elimination of the leukemic clone to ensure durable remission. So venetoclax dosing is usually in ml 100 mg on day one, followed by 200 mg. 400 mg is the maximal dose. But in India, we are giving these drugs with antifungal prophylaxis like posaconazole or voriconazole, I think. So the dose is 100 mg we are using in Indian context, and it can be we can give it to some our Indian patients because of some logistic issues. So 100 mg we are using along with the posaconazole prophylaxis. So venetoclax in AML is the preclinical trials and treatment positioning. The first is paradigm. It's the untreated AML, the patient who are eligible for intensive chemotherapy. So the paradigm study design, it is randomized multi-center phase 2 trial. The patients are more than 18 years of the age, untreated AML, eligible for intensive chemotherapy. The patient are divided into two arms, EJA plus VEN, and the other one is a conventional intensive chemo. This is 7 plus 3 or CPX 351. The ESA plus when two cycles, two or more cycles can be given if and then after conventional chemotherapy, if the residual disease is there, second induction is given, and the ablation, wait for counter recovery and then consolidation with the high deck. The transplant allowed at time following disease response. The way these are baseline characteristics, the total patient, all patients are 172 with ESA and when the patient number of the patient is 86, whereas the total patient, the remaining patients are on intensive chemotherapy. These are the basic, the ELN risk stratification, favorable are approximately 12.8%, intermediate 15%, and adverse risk is 72.1%. Both arms has adverse risk patient approximately same numbers. The EFS in this paradigm study, the intensive chemotherapy, the PFS is low, whereas in Azavan, the PFS is good. The median EFS in Aza and Van is a 14.6 month, when an intensive chemotherapy it is just half, less than half. And 1 year EFS is 53%, whereas in intensive chemo, it is 36. The response rates, the complete remission is 55.8% as a Van arm, but intensive chemo, it is approximately 48%. The complete remission with the partial hematological recovery is 8 versus 1, and the complete remission with incomplete hematological recovery 14 versus 3.5. So in all these parameters, the Azavan arm shows good results in comparison to intensive chemotherapy. The quality of life, anxiety, depression, symptom burden, all are less in Azavan because of there is a hospitalization length or stay of the days is significantly lower in Aza and Ven arm in comparison to intensive chemotherapy. It is only 15 days, approximately 15 days in Azavan arm, and intensive chemo it is more than a month. And hospital days in the first 6 months in 41 days, where it is approximately 60 days. And ICU admissions in first 30 days are zero in Azavan arm, whereas in intensive chemo it is approximately 10. So, however, the safety profile, when comparison is done between Azavan and intensive chemo, the Azavan was associated with significantly lower rates of grade 3 infections, 15% versus 21%, and the bleeding rates and the trend toward lower 60-day mortality rate in Aza and Ven arm. The next trial is a YLA. It is done on treatment AML patients who are ineligible for standard induction chemotherapy. The YLA trial is a comparison is done between AZA plus azacitidine plus venetoclax versus azacitidine plus placebo. So these patients are previously untreated. Primary endpoint is overall survival, and the complete remission with the incomplete hematological recovery, and the key secondary endpoints are the CR plus CR rates, and the EFS OS. These are the baseline characteristics of both arms. The patient in Van plus AZA arm is approximately 286, wherein placebo and AZA arm is 145. These the more than 75-year age patients are approximately 61% in AZA and Van arm. On PBO, these are approximately 60%. De novo AML are 75%. Both arms has 75% de novo AML or secondary AML approximately 25% in both arms. So the follow-up shows the median duration of follow-up is 43 versus 42, the patient remaining on treatment at the time of current analysis is 25, discontinued treatment is 91 versus 145. So on safety analysis, the grade 3 or more than grade 3 adverse events are present in both arms. It is slightly more in AZA plus ven arm to venetoclax. Serious adverse event at the same, the uh, adverse effect leading to ven or placebo discontinuation is slightly higher in the AZA and ven arm. The overall frequency or adverse effect are similar between both arms, but there is some more hematological events in AZA and ven arm due to venetoclax. But overall survival, all patient, if we see the ven plus AZA, 77.6% in the ven plus AZA arm and 95% in PVO in placebo and AZA arm. Median OS is 14 point, approximately 15 months in ven plus AZA arm, whereas in placebo and AZA arm it is less than 10 months. With a hazard ratio 0.5, the patient with IDH or IDH1, IDH1 or IDH2 mutations, there is a 80% versus 100. The patient, those achieves complete remission with incomplete hematological recovery, and MRD is less than 10 to power minus 3. The AZA-VEN arm are these patients 62 versus 82%. So patient with the patient who are MRD positive with CR or CRI, the 79% 96. So continued OS benefits with AZA or VEN arm is observed in all the analyzed groups.
Sir, sorry to interrupt you, sir. Please conclude the session.
Yes. So investigators' conclusion in patient with newly diagnosed AML, those patients are ineligible for intensive chemotherapy. VEN plus AZA showed ongoing OS benefit in comparison to azacitidine monotherapy. The other trial is the phase 2 trial. It includes cladribine, low-dose Ara-C, venetoclax, and the cycles are alternating with azacitidine venetoclax in newly diagnosed AML patient. So induction followed by consolidation. In induction, cladribine, cytarabine, venetoclax has been given. In consolidation, after 2 cycles, 1 or 2 cycles, the alternate cycles has been given clad, LDEC plus venetoclax and AZA plus ven. Primary endpoint composes CR rates and secondary OS, DFS, ORR. So is this the in this study uh, the adverse risk effect of patient population median OS in adverse effect 24.7 months, and the favorable is not achieved. The intermediate is 50%, whereas in adverse risk so I'm finishing it sort of in this study, the clad LDEC when alternating with AZA older patient with newly diagnosed AML and the patient who are unfit for intensive chemotherapy, the MRD negativity rate of 76% and CR or CR rate 86%. And the clad LDEC or venetoclax alternate with AZA favorably to standard HMA but novel treatment. Only TP53 mutated patient required still some other targeted therapy. Otherwise, all the other groups, all the other mutation has advantages of this. The conclusion: venetoclax transformed the treatment of AML. That the evidence supports VEN plus AZA is standard of care for newly diagnosed intensive chemo ineligible patient. Novel triplet frontline regimen has been come that if the patient IDH1 mutated, we can add HMA plus venetoclax plus ivosidenib, or if the patient relapsed refractory AML, or we can use it to bridge to transplant strategy. Now it's time to just look for some targeted therapy and improve the survival of the patient if the patient is intensive chemo ineligible. Thank you.
Thank you, sir. Thank you for the excellent talk.
Thank you, sir.
Moving
Thank you, sir.
forward.
So do you see Indian scenario patients receiving clad, LDEC and VEN alternating with VEN and AZA? Are we looking at a scenario where we can use CLAD, LDEC, and WEN in our Indian patient population?
Actually, till now we haven't used this. Actually, till now we haven't used this. We are using just ASA and when ASA and venetoclax, and we are giving the intensive chemo eligible patient along with the target midostaurin, and we just giving some ivosidenib IDH1 mutated patients actually now. So right now the treatment is same. High risk, go for transplant. Intermediate risk, if you have MSD, go for transplant. Favorable, just consolidate with high deck after giving intensive chemo. If you achieve remission with Adaven, other patient is favorable risk, you should go some anthracyclines to them. After once patient is stable, give 3+5 or some anthracycline add and give consolidate the patient with that actually. Na. This is right now we are doing actually. This is the
Correct,
main.
correct. I agree. I think, but it's a good data of alternating CLAD.
Yeah, yeah, it's
Versus
good. It's very yeah,
data.
it's very good data actually. I find it good. We can give actually. We can give
Yeah,
few
yeah. I
patients
think
they are
we
eligible.
can plan it in our practice somehow.
Yeah.
Okay, sir.
Although
Thank
we
you.
are not getting cladribine in our setup actually, in government setup, but we can give
Okay.
it. It is not a costly drug. It is
Yes, yes.
we can give it
Absolutely.
actually. Yeah, yeah, yeah.
All right.
Thank you,
All right.
sir.
Thank
Thank
you.
you, sir. Thank you so much. So moving forward,
I thank Dr. Ankit sir for this opportunity. You upload the presentation.
sure, ma'am.
I'm going to talk about recent developments in the management of intermediate HCC with Atezo plus PEV. Next slide. Next slide. So, as we all know, despite the advances in the treatment option, the global incidence and mortality of HCC continue to rise. It's the sixth most common cancer worldwide, and in 2018 only 8 lakh 50,000 people were diagnosed with new HCC and 8 lakh died from it. So the rising mortality, it's the third most common cause of mortality globally, and the WHO estimates that more than 1 million people will die from HCC in 2030. It accounts for 90% of all the liver cancer cases. In the last few decades, HCC-related mortality has increased faster than mortality related to any other cancer. And like we know, it's a complex disease, can have underlying CLD, hepatitis, viral etiology, and liver cancer. This requires a concerted approach to treatment, characterized by complex management of tumor burden and liver function by care providers across specialties. Next, please. So the established standard of care from a long time now is IMDA 150, which was a phase 3 study demonstrated that PD-L1 antibody Atezo and anti-VEGF bevacizumab extend survival compared to sorafenib in the first line treatment of advanced and intermediate stage HCC, and it has been approved for unresectable and metastatic HCC. Next, please. So I think even the previous discussion was about TACE. So for this intermediate stage B, BC, and C staging, we usually give TACE, which is the standard of care for intermediate stage HCC. Next, please. So dilemma of TACE alone in intermediate advanced HCC is the response rate usually reduced after repeated TACE alone. It fails usually when the tumor burden is high, and there is, of course, room for improvement in the efficacy of TACE alone. Next, please. So this slide shows how the response rate reduced after several TACE procedures in HCC with TACE alone. So if we can see, like with the response rate with first TACE was 40%, decreased to 26 after second, decreased to 25% after third, and decreased again to 25% with the fourth TACE. So even the disease progression kept on increasing with the number of TACE performed. So the disease progression after first TACE was 18% and reached to 27% after fourth TACE. Next, please. So the patients with moderate to high tumor burden seem to have poorer responses to TACE. Uh, they did a study where 128 patients with BCLC stage B HCC who underwent TACE as a primary treatment were enrolled in the Veterans General Hospital. The BCLC stage B patients with smaller tumor size or within up to 7 centimeter were shown to have a better survival with TACE alone. And there's something called up to 7 criteria. The sum of the size of largest tumor and the number of tumors within or beyond 7 is a practical standard approach for liver transplantation. And this was also further extrapolated to performing TACE. So what they realized is less than 7% did fairly well with TACE, but the moment the size of the tumor increased to more than 7, the TACE failure rate increased. Next, please. So again, patients with moderate and high tumor burden in 6 and 12 model seem to have a poor response to TACE alone. So this was a multi-center study to develop a predictive model that accurately predict TACE outcomes and has helped treatment selection for patients with intermediate stage HCC. So based on a multi-center nationwide cohort, 1,000 patient recommended TACE candidates developed a 6 and 12 score that can predict individual outcomes with favorable performance and discrimination. And with the sum of tumor size and number, less than 6, more than 6, but less than 12 and more than 12, the score identified 3 prognostic strata presenting significantly different median survival. So for less than 6, it was 49 months. 6 to 12, it was 32 months. And 15 months if the tumor size and the number exceeded more than 12. Next, please. So large-scale real-world evidence, especially in China, they did a lot of studies which combined TACE because, as we know, the intermediate high tumor burden disease fails with TACE alone. So they added immunotherapy with TACE and the chance 1 to 2201 and chance 023 study. All of them showed that adding a TKI or a PDL1 with TACE did improve the median overall survival. So coming to the mechanism of this combination, TACE combined with targeted immunotherapy synergistically modulates the tumor microenvironment to enhance the immunotherapy efficacy. So it induces apoptosis and inhibiting tumor cell proliferation. The tissue hypoxia again increases the PD-L1 expression and induces tumor angiogenesis. And immunotherapy blocks PD-1, PD-L1 interaction, activates T cells and enhances the efficacy. And even the VEGF activity is increased with TACE because it promotes neovascularization. Next, please. So coming to this phase 3 trial, TACE, which was a randomized multi-center open label trial of atezobev versus TACE in intermediate stage HCC. Next, please. So what they did was, it was an open label phase 3 trial. The inclusion criteria was HCC. So the eligible for TACE treatment, and including the unresectable BCLC A, B, and C with both portal invasion and BCLC-C for performance status 1. So the sum of tumor maximum diameter plus tumor number was more than 6. As we saw that this is where the less than 6 is where TACE did fairly well, but when it came to more than 6 is where TACE was not doing that well alone. No prior systemic therapy, childbirth gate, and no extrahepatic spread with performance status of 0 to 1. The stratification factors was baseline AFP, history of non-curative local therapies, and if vascular portal invasion was present or not present. So they gave TACE with atezobev in the experimental arm, and the other arm was only TACE. And the primary endpoint was OS and the PFS. So all the baseline characteristics were well divided, and most of them did not have portal vein invasion. As we can see, 98% and 97% did not have portal vein invasion. Also, they took majorly the hepatitis B subgroup. Others were fairly smaller in number, and all of them had a score of the tumor burden was more than 6. So the PFS increased with TACE plus atezobev 11.3 versus 7.3 months. The hazard ratio was also good, 0.7. And even by the RECIST, the PFS was better with TACE compared TACE plus atezolizumab compared to TACE alone with a hazard ratio of 0.64. So in this forest plot, almost all groups showed a better PFS with atezolizumab. It favored the atezolizumab with TACE compared to TACE alone. And though the overall survival is not mature, so I think it's difficult to comment. The graph is kind of merging, but I think we'll get that answer later once the data is mature. So the overall response rate again with atezolizumab plus TACE was better as expected, 81% versus 66% with TACE alone. And the best overall response also was better with TACE plus atezolizumab compared with TACE alone, 49% versus 33%. The adverse reaction, same, the IO-induced adverse reactions were seen with adding atezolizumab, slightly more proteinuria, post-embolization syndrome, and altered AST compared to TACE alone. So Talentase enrolled. So there were 3 trials: LEAP 012, LEAP 0, and Talentase. So here in the Talentase Emerald 1 and LEAP 012. So Talentase was the only one which did TACE on demand, which is kind of what we do in the real world. The other 2 trials had TACE as per protocol, and also the Talentase took a more higher tumor burden disease, which is expected to fail with TACE alone. So the key takeaways: the Talentase took a higher tumor burden, which is commonly seen in our clinical practice as well, with a score of more or equal to 6. On-demand TACE again is what mirrors the real-world practice, offering a flexibility to individualize treatment based on patient response rather than adhering to a strict schedule. So treatment goal for patients with high tumor burden, it delivers ORR of 49%, providing aggressive tumor control that aligns with clinical goal of downstaging patient towards a potential curative resection. Talentase also demonstrates that on-demand TACE plus atezolizumab significantly improved the PFS compared to TACE alone with intermediate to high tumor burden, establishing a potential new therapeutic paradigm. And the safety profile also was generally manageable. So can initiation of systemic therapy early in the treatment paradigm support better outcomes? For that, one more trial, ABC-HCC, phase 3 randomized trial, which compared atezolizumab versus TACE in the intermediate stage HCC. So the study rationale was it is unknown if atezolizumab is more efficacious than TACE in patients with intermediate stage HCC who would be treated with TACE as per the standard of care. So several trials assess the benefit of adding systemic therapy to TACE versus TACE alone, but the ABC trial directly compares atezolizumab versus TACE. So they did not do TACE at all, and they just gave atezolizumab. So like we saw, the key eligibility criteria, the inclusion criteria was intermediate stage HCC, which was not amenable to curative surgery, liver transplantation, or curative ablation, but disease amenable to TACE. No extrahepatic disease, childhood performance status 1, and no presence of untreated or incompletely treated varices because we are giving bevacizumab. So these were the inclusion criteria. So they saw the time to failure of treatment strategy. So what they considered in the atezolizumab was radiologic progression, and for TACE they considered both radiologic progression and stable disease was also considered as time to failure of treatment. And second condition was any of the following: loss of clinical benefit or unacceptable toxicity, liver function deterioration, and therapy not further applicable for other reasons. So the other endpoints were OS, overall survival, and progression-free survival. And in an exploratory endpoint, they also saw the PDL1 expression. So they took 320 patients in more than 70 sites. 214 are recruited. And interim analysis, 2 time points for efficacy, futility of failure to treatment strategy was C. So first at 33% of the information fraction, which was reached on 13 June, and second is expected in the end of the year. So what they saw in the next please, what they saw in the first interim analysis. Next please. Again, the baseline characteristics were equally divided among both the arms. Most of them did not have vascular invasion, and BCLC 70% were BCLC B subgroup. And the time to treatment, failure of treatment strategy was here also the arm with atezolizumab did better actually compared to TACE alone. So exposure to treatment, the median cycles of atezolizumab was 12 and the median cycles of TACE was 2. And the reason for end of therapy failure of strategy with progressive disease was 33 with atezolizumab versus 46 with TACE. So concluding this, the results of the first interim analysis provides important insights into the efficacy of atezolizumab versus TACE. Based on these findings, the trial is progressing to secondary interim, and this will give us an important conclusion if we can skip TACE and go only for atezolizumab in this higher tumor burden, intermediate risk BCLC subgroup. So the versatility paradigm, atezolizumab as a backbone of intermediate HCC management. It provides the most robust evidence in the HCC space. Strategic positioning segment, if there is high tumor burden, localized large solitary tumors, we can go for atezolizumab plus TACE as we discussed in the TACE study. It's an ideal choice for downstaging as supported by the ORR and PFS. The on-demand real-world advantage, allowing IR to tailor TACE to radiological response, reducing over-TACing the subsequent loss of hepatic reserve. And if it's a diffuse multifocal, again, we can go for atezolizumab. It's significantly longer duration of stable management and the liver protection through avoiding the damage which usually we see by TACE. So thank you.
Thank you, ma'am. Thank you for such a lucid talk.
Thank you, Dr.
So-
Mansi. Thank you.
Thank you.
So technical team.
Yeah, done.
Okay, thank you. So moving forward, we have the next session, which is sponsored by Roche. And for this, I would like to invite Dr. Vishnu Sharma, Professor, Department of Clinical Hematology at SMS Medical College, Jaipur, for the talk on driving change in DLBCL. Over to you, sir, for your talk.
Thank you for the opportunity and kind introduction. So, can I share slides from my side?
Yes, sir, definitely.
Can you see my slides?
Yes, sir.
Slide is visible. No?
Yes,
And
sir. It's moving.
Good evening, everybody. Speaking on polatuzumab vedotin in the management of diffuse large B-cell lymphoma. So this is a Roche sponsored session. And this is the disclaimer from the Roche side. So as we all know that the lymphoma, around 30% of the lymphoma are constituted by the Hodgkin's lymphoma and 70% by the non-Hodgkin's lymphoma. And out of these, the DLBCL is one of the most common non-Hodgkin's lymphoma, which accounts for around 42% of the all non-Hodgkin lymphoma cases. Coming to the principle of DLBCL therapy, so we need complete remission for majority of the DLBCL. Cure must be accomplished with frontline therapy. Drug must be delivered at curative doses. Onset of action and the clearance of the disease should be rapid, and we need to achieve deep and durable remission with aggressive therapy, which is least toxic. So DLBCL journey, we all know that the DLBCL with first line treatment, we can achieve 60% cure rate. So 60% patients gets cured with the currently available therapy, that is R-CHOP. But 40% patients becomes primary refractory or ultimately these patients relapse. So these patients requires second line treatment in the form of CAR T cell therapy or bispecific drugs or drugs like polatuzumab. So these are the patients where unmet needs is still existing. So in 1976, the R-CHOP becomes standard of care. After almost 20 years, rituximab was approved for treatment of the DLBCL along with in combination with CHOP, so that the regimen become R-CHOP. And after more than 20 years, we have effective therapy, which is effective in terms of improvement in the progression-free survival for patients of DLBCL in the form of polatuzumab. So we have polatuzumab in combination with other drugs for treatment of relapse or refractory DLBCL. So coming to the data from the India, so it was a multi-centric real-world prospective observational study where close to 1,400 newly diagnosed DLBCL patients were enrolled who received R-CHOP upfront. The outcomes, the overall response rate at 6 months was 90%, 2-year progression-free survival was 69%, and 2-year overall survival was 79%. But it was 8 to 10% less than the West because majority of our patients are diagnosed late, mainly in the stage 3 and stage 4. So the overall survival of our patient is almost 10% lesser compared to the Western patients. So unmet need, it still exists for patients with high IPI, age more than 60, non-GCB phenotype, dual protein expression, and patients with double hit lymphoma like MYC and BCL2 rearrangement. R-CHOP works well in patients with low IPI, early stage disease, and GCB phenotype. So on the right hand side, these are the patients where R-CHOP failed to achieve a deep and durable responses, and we need like drug which can improve the outcome of these patients. And there was the study, multiple study, which investigated various drugs like obinutuzumab or drugs in addition with R-CHOP like lenalidomide, bortezomib, ibrutinib, bevacizumab, or chemotherapy like gemcitabine or DA-POCR. So multiple drugs, multiple combination has been tried, but everything has failed. So there is significant unmet need to improve treatment outcomes in DLBCLs, especially in patients with advanced stage disease, ABC phenotype, high IPI. So these are the patients where R-CHOP is insufficient and addition of other drugs are ineffective. So Pola-R-CHOP is the only regimen approved in the last 20 years that has improved treatment outcomes in first-line DLBCL. So it is FDA and CDSCO approved drug for these subset of patients. So we all know polatuzumab vedotin is an antibody drug conjugate targeting CD79B, which is ubiquitously expressed on the lymphoma cells. So it is the ADC, which binds with the CD79B expressing cell selectively. And this ADC gets internalized and it causes microtubule disruption and ultimately apoptosis of the malignant cells. So it selectively binds with the CD79B positive lymphoma cells. So it was investigated in the Polarix trial, which was a global randomized double-blind placebo-controlled trial, where close to 440 patients in each arm were randomized into Pola-R-CHP and R-CHOP, and patient received 6 cycles of 21 days. So the total 879 patients were randomized to 1:1 fashion. Newly diagnosed DLBCL aged between 18 and 80 years of age, IPI between 2 to 5 with good performance status between 0 to 2. So the group 1 received Pola R-CHP, group 2 received the R-CHOP. Subsequently, for 6 cycles and for 2 subsequent cycles, rituximab at a dose of 375 milligram per meter square at cycle 7 and cycle 8 in both the arms. Primary endpoint was PFS and secondary endpoint was EFS, PET-CR, DFS and OS. So coming to the 2-year progression-free survival, so you can appreciate in the curve that 2-year progression-free survival was significantly superior in the group who received Pola R-CHP. It was 76.7% compared to 70.2%. So almost 6-7% difference in PFS was there at 2-year. Long-term data is also available. When it comes to the 5-year progression-free survival, it was 64.9% with Pola R-CHP compared to 59.1% with R-CHOP. So almost 6% PFS difference at 5 years. So this PFS difference was sustained over the period of time. Patient treated with Pola R-CHP required 23% fewer subsequent therapies versus patient treated with R-CHOP, and this was applicable for all kind of therapy and all subset of patients. Although overall survival was comparable in both the groups, so in the intensity to treat 5-year overall survival, hazard ratio is moving away from unity with extended follow-up, although the difference is not significant. When it comes to the Asian cohort, trend toward OS benefit at extended 5-year follow-up was favoring Pola R-CHP. So 5-year overall survival was 84.6% in the Pola R-CHP compared to 77.7% in the R-CHOP arm. So it was almost 7-8% OS difference was there at 5 years. So PFS outcome shows consistent treatment effect of Pola R-CHP across subgroup in the global population. So in all the subset of patients, whether it is age less than 65, more than 65, or high IPI or low IPI, bulky disease, baseline elevated LDH, extranodal sites more than 2. So in all the subset of patients, Pola R-CHP was superior compared to the R-CHP. So PFS by subgroup, including high-risk subgroup, generally favors Pola R-CHP. However, subgroup analysis are exploratory and generally underpowered, especially when it comes to the overall survival. So overall survival was also in all the groups, overall survival was also superior in the Pola R-CHP compared to R-CHOP. So we all know that DLBCL is heterogeneous, molecularly heterogeneous disease, and the outcomes are different in different subgroup of patients. So based on the genetic profile, patient can be categorized into C1 to C5, and outcomes are different. So in the Polarix, investigator assessed PFS by cell of origin. It was found to be superior with the R-CHP compared to 56% with the R-CHOP. Although the difference was not significantly difference in the GCB subtype, and in the unclassified subtype also, the difference was not significantly different. So it was significantly superior for ABC subtype of patients. So when it comes to the cell of origin, ABC subtype patients benefited the most. When it comes to the lymphgen subtype, based on the presence of these mutations, EZB, MYC, ST2, BN2, A53N1, MCD. So these are the, based on this lymphgen subtype also, the Pola R-CHP was significantly superior for MCD and EGB subset of patients. So this can be appreciated for cluster of like 5D cluster also, where the polar R-chip was found to be superior for patients with C5 and C1. When it comes to the dark zone signature, the polar chip was found to be superior for patients with high risk molecular signature behavior compared to the patients where dark zone signature was negative. Polaric patient with DLBCL and extended disease demonstrated superior PFS with polar R-chip compared to R-CHOP. So with extranodal disease by investigator population, the polar R-chip was found to be superior compared to the R-CHOP. Elderly subgroup, 284 elderly patients with the median age of 74 years, ranging from 70 to 80, where 68.7% had an international program, the IPA score of 3 to 5, and PFS for polar R-chip for elderly patients was superior compared to R-CHOP, although the difference in overall survival was not significantly different, although it favors polar R-chip compared to R-CHOP. But difference was not significantly different. However, trend of improvement in OS was there with polar R-chip. So the polar R-chip shows a favorable benefit risk profile compared with R-CHOP in when it comes to the any grade adverse events. So grade 3, grade 4. So there was not of a much difference in when it comes to the grade 3, 4 adverse events and serious adverse events. Safety profile remained comparable between treatment arms with no increased risk of long-term follow-up. Select adverse events of particular...
So
Yes.
sorry to
So
interrupt you,
finishing-
sir. Please conclude the session in next 2 minutes.
Yes. So peripheral neuropathy was slightly more in patients with polar R-chip, although the grade 3-5 difference was, there is no significant difference. So there was a less than 5% difference in hematological toxicity and infections in the polar R-chip versus R-CHOP arm, and fewer secondary malignancies were observed with the polar R-chip. However, the follow-up is only 5 years. Peripheral neuropathy, there is not of a much difference in when it comes to the peripheral neuropathy, although the peripheral neuropathy is less in the polar R-chip compared to R-CHOP arm, and it was consistent across in the subsequent cycles also. So newly released EHA guidelines in the first line DLBCL recommends for patients where 2 or more than 2 risk factors are there in the form of age, the stage 3-4 disease, high LDH, poor performance status, extranodal sites more than 2, and age less than 80. So these are the subset where polar R-chip is recommended by the EHA guidelines, and it is also there in the NCCN guidelines in the first line set for stage 1-2 disease and stage 3-4 disease. So conclusion of this trial in over 20 years in the benefit risk profile over R-CHOP follow-up analysis of polar study confirm and ongoing and encouraging PFS benefit and indicate a positive trend in the OS in favor of polar R-CHP. However, the difference in OS was not significant. Benefit of polar R-CHP holds even more important setting with limited availability access to efficacious treatment in relapsed refractory DLBCL in the second and third line setting, and polar R-CHP is category 1 preferred regimen as per NCCN guideline, also recommended by the NICE guideline, both for stage 1-2 disease and stage 3-4 disease. With this, I thanks the organizer for giving this opportunity.
Hello, Dr. Vishnu, good evening. Hello.
Yeah, hi, good evening. Yes.
Yes, Dr. Pramod sir. Yes, please.
Just a quick question, sir. What is your experience of polatuzumab in DLBCL, especially if there is a refractoriness to R-CHOP? In GCB,
So we have used
DLBCL, GCB subtype, refractory, there is... Yes, sir.
So
Yes,
Pola
sir, please.
BR we have used in patients where patient relapsed after receiving R-CHOP. Although this difference is like the patients who relapsed after like 1 year, 12 months of receiving R-CHOP is the subset where benefit is like most
So if
benefit
there is
is there.
afferent
Patient who is relapsed
refractory, so there is a residual disease, dual 5, post R-CHOP, will you like it is DLBCL GCB type? Will you prefer it for a polar BR, or you plan it for a CAR T?
Does the patient
Limited disease. Again, I that there
but
is
again,
one or two area जहाँ पे dual 5 है, CAR
but
T
again,
और polar BR.
RT would be the best
CAR
I,
T will be.
I don't think
Yes.
Pola will work in this, sir. I
Yes,
also
yes.
don't think Pola should work in this.
Well,
Primary refractory, I think Kati
is a better.
is
Yes.
to go for.
Thank you. Thank you, sir. Thank you.
Thank you, Vishnu sir. Thank you.
Thank you.
Can we call upon our next speaker, please?
So, good evening once again, everyone. And we have our next speaker, Dr. Abhishek Sharma, consultant medical oncologist from the Goel Hospital and SKG Cancer Center, Jodhpur. Good evening, Dr. Abhishek, sir. Over to you for your presentation. And you have 15 minutes to close your sessions. Over to you, sir.
Yes,
Welcome, Abhishek
definitely.
bhai.
Hi, boss. Good evening, boss.
Good evening.
So thank you, Ankit, boss, for this opportunity to me. So I am here about teclistamab, especially in the early relapse refractory multiple myeloma. Definitely a game changer, transformative evidence. Right now, we all know in this era, multiple myeloma definitely a diverse disease, and right now we are using four drug combination, especially in the high risk patient, and the uses of the anti CD138, especially diatomab based regime. So it's a very difficult task to give a patient a second line or third line because the PFS is very bad in the second or third line. But yes, teclistamab changes this profile of this disease to improve our survival as well as response rate. So basically, when I move to the mechanism of action, this is the first in class of the cell T cell directing bispecific antibody designed to bind BCMA on the malignant plasma cells and definitely CD3 expressive T cell as well as BCMA. So this is the both side that drug going to be bound. And yes, after that T cell activation lead by the cytokine induction and subsequent lysis of the BCMA expressing myeloma cells through the secretion of perforin and granzymes definitely. So this drug basically developed by the duo body platform definitely, and the mechanism of action is the bispecific only. So when I move to the just simply the body weight regime, so simple body based regime this drug has have and convenient subcutaneous dosing schedule right now is introduced. So this is the potential alternate to this part. And when I move to the dosing part, you can say this is the most important part of this drug. Teclistamab is indicated as a monotherapy for the treatment of patient relapsed refractory, as well as right now the real ASCO update right now. So we can use in combination in a first relapse also when the patient use some IMiDs, proteasome inhibitor, and CD38 antibody, and showing demonstrate disease progression on the last therapy. So the administration of teclistamab on a day one definitely step up dose we are planned to reduce the toxicity, especially in the CRS. So dose is 0.06 milligram per kg. On a day 3, you have to step up to 0.3 mg per kg, followed by the maintenance dose on a day 5 and up to the after the day 12. So 1.5 mg per kg every 2 week in a patient who have a complete response more than 6 months. So teclistamab initiate according to the step dose schedule to reduce the incidence of the severity of CRS. And due to risk of CRS, patient should be instructed to remain within proximity of healthcare facility as well as to monitor sign and symptom, especially in a 48 hour after admission of the all dose within the step up dosing schedule. So outpatient patient admission of teclistamab can be feasible with the careful patient selection and at either close at home monitoring. So what the preparation you have to do that infectious preparation like experiencing administering bispecific antibody in an inpatient setting, assess to hematology department that is familiar with the CRS and ICANN and infection as well as emergency department, ICUZ, other SCP to guide the all sign and symptoms. And for a patient, definitely with a good ECOG, no high tumor burden, rapidly progressive disease. If comorbidity, these must be well controlled. presence of caregiver residing at the same home at the to monitor the AE, and he should be educated about the adverse event as well as symptom and sign of the CRS, because some Western data, as per data as well as their practice, they are using tacrolimus on the OPD basis. But yes, this should be facility would be there as an infrastructure as well as patient rated also. So the treatment initiation action prior to step-up dose monitoring: administer mandatory pre-medications like a paracetamol, anti-allergic, and dexamethasone. Provide patient caregiver with the simple education on the sign and symptom of CRS and ICANS. Provide potential notice and card to the patient and caregivers. Provide patient prescription for a simple parameter, thermometer, BP monitoring, pulse oximeter. This education should be done. Adverse post-SCDU management: patient caregiver monitor temperature, blood pressure, means you can say vitals, as well as simple management by the patient as well as the caregivers, and as well as HCPs. Those are practiced in this part. So definitely all pre-medication before that, and after that we have to check for every symptoms, every sign, and as well as close vital monitoring that will help to detect the CRS as early as possible, because the mild CRS can be easily manageable, but yes, for a higher grade, grade 3 and grade 4, we have to made some quick action as per their severity of the symptoms. So, uh, if the patient is somehow duration of the interruption is less than 62 days, there is no need to repeat step-up dose schedules. But it's more than 60 days up to triple 11. So restart as the step-up dose 2, and if there is a more than 112 days, definitely restart with the same dose schedule as on a day 1 lock-in. So this is the retrospective analysis of 61 patients, especially by the Majestic 1 trial, who had treatment interruption more than 28 days, found that only 2 patients had CRS when restarting teclistamab. So dose interruption between 62 to 111 days result in the teclistamab serum concentration lower than the dose after SU2, but similar to a higher than. Just give me a second. Yeah. But is a higher than after step-up dose 1. Therefore, repeating step-up dose to be required. So teclistamab can be restarted after a prolonged treatment interaction with minimal risk of CRS, and repeating step-up dosing is recommended for interruption more than 62 days. This is the conclusion. After 62 days, we have to step up the dose. Otherwise, you can continue with the same dose. So teclistamab is a first-in-class same antibody we already discussed. This is administered at a personalized weight-based dose and has a convenient subcutaneous dosing schedule also, which can offer flexibility of the OPD as well as potential for alternative dosing. Teclistamab can be restarted to minimize the risk of CRS. If more than 62 days, that definitely we have to repeat the step of dosing. A patient who have more than minimum of 6 months with a more than CR, a reduced drug dosing frequency of 1.5 mg per kg every 2 weeks may be considered. Less frequent dosing of teclistamab 3 mg per kg every 4 weeks is under evaluation but not yet approved. So this is a trial Majestic 1. We can clearly see as a monotherapy, teclistamab demonstrate deep overall response rate is around 63%. It's a more than 2 line. Definitely, this is a quite acceptable and good response rate. CR rates around more than 46%, VGPR around 60%, durable response, median PFS around 11 months, median duration of response not reached for the patient, those who are achieving more than CR in the patient with the teclistamab, especially in the refractory arm. Follow up around 2 year at the median follow up 2.5 year. OS and PFS not reached in patient, those who especially develop CR. So you can clearly see in this all overall response is quite good. Duration of response is high in the patient with CR, definitely, but it's good also in VGPR as well as more than VGPR in the patient PFS as well as duration of response also. And when you look, the teclistamab demonstrates consistently deep and durable responses and a manageable safety profile with the diverse cohort from the pool from the clinical trial. So this is the pool of the clinical Majestic 1 with Chinese cohort and phase second Japanese cohort. That's clearly showing overall response rate is around 66%. Here you can see a good number of CRs around 50%, and you can see the VGPR rate around 63%. So that is quite highly impressive with the And this is the post-hoc analysis, especially in the majestic web, because this study uh, consider registered in the pre-COVID era, and during COVID era, there are some patients they lost. So they censored the data, and after the censoring the COVID-19 data, you can clearly see a good PFS. This is around 15 months and around 28 months of the median OS with the good duration of response that is around 26 months. And when you look at the their quality of life, that patient reported sustained and clinically meaningful improvement. When you look at the high risk, high health rate of life in a patient, especially in the CR, there are excellent improvement in the health rate quality of life compared with the VGPR and PR. And you can clearly see in this both chart, and definitely they are showing a clinical meaningful improvement from the baseline. So for the majestic trial, respond is 63, CR more than CR is around 46%, favorable responses, good median flow, and not reaching the median OS as well as PFS. After sensing the COVID-19 data, there is excellent improvement in the PFS as well as OS. And yes, on the basis of a health-related quality of life, clinically meaningful improvements and sustained improvement we are seeing. This definitely is a locomotion study that highlighted that patient with the teclistamab were 2.3 times more likely to reach overall response rate with significant improvement in the duration of response as well as PFS compared with the real world practice treatment. On the pooled analysis of the locomotion and the moment study, there is 3 time and 2 time and 3 times longer improvement in the median PFS, median OS, and as well as duration of response with the teclistamab. So definitely there is some question, especially regarding the patient with the who is the penta.
Dr. Abhishek sir, if you allow, you have another Abhishek sir. You need to conclude with your final
Yeah,
comments.
definitely. I'm going to conclude within the next 2 minutes. So, patient with the more than 75-year-old, patient with the penta-refractory drug, patient with the high-risk cytogenetics. So, definitely these are the questions. What the standard of treatment for the patient? Because these are the patient, those who are very poor responses. But when you have an option with the teclistamab, this is the data on the drug. When you look at the 75-year-olds, when you look at the high-risk cytogenetics and penta-refractory, you are clearly seeing there is a good clinical response rate we are seeing. And after that, you can clearly see there is a benefit in the median OS as well as PFS also. And this is for the patient, those who are heavily pretreated patient, prior expert to BCMA target therapy. So on this cohort, you can clearly see there is excellent benefit in PFS and OS also. So which line of treatment we have to use for the teclistamab? There is the data.
Dr.
Those who
Abhishek
are
sir,
having,
sorry to interrupt, but you need to conclude, please.
yeah. So this is a line of treatment, less than 3, more than 3, definitely benefit is seen as per as early lines. So I'm just summarizing, especially in the CRS, you have to examine first sign and symptom and prophylactic use of tocilizumab in the patients. The tocilizumab, and those who are using prophylactic tocilizumab, definitely after tocilizumab, there's a decreasement in the risk of especially CRS. And ICANS, definitely we have to measure, but on the median fall of 2.5 years, they more or less similar. And yes, before the most common side effect with the seen with the TACLI, that is CRS, definitely neutropenia management will lead to the infection, and next is the ICANS that we have to aware of all about it. So I am just concluding. This is the high response rate, with already data, and yes, new safety concern is only CRS. Rest are manageable. Thank you.
So thank you so much, Dr. Abhishek, for such a lucid presentation. Now we are moving to next very, very interesting, and this is a panel discussion. To moderate this panel, may I have a pleasure to invite Dr. Asim Samar, sir, Director for Medical Oncology at the prestigious CK Birla Hospital. Dr. Abhishek, sir, can you allow Dr. Asim to share his screen, please? Thank you. So may I request all the esteemed panelists to open up their videos. We have respected Dr. Lalit Sharma, sir. Thank you so much for joining. We have Dr. Pramod, sir. We have Dr. Aditi Tanke, Dr. Suparna Rao, and Dr. Rishabh Jain. Sir, all your panelists are available. Asim, sir, over to you for
Thank
your
you.
moderation.
But I don't know why the sound is echoing here.
Yeah, I think there is some some issue with the
Support team, can you please check?
Yeah, just a minute. I will check.
Meanwhile, are these slides visible to you?
Yes, sir. Please.
And there have been a lot of technical glitches. This is the very new technical glitch that I have heard. The sound is echoing.
कोई पीछे से बैकग्राउंड से बोल रहा है.
But they can mute the background noises. Okay, so we'll start. And actually, introduction missed in the echoing sound, so I will reintroduce my panelists. I welcome Dr. Pramod Kumar. He's assistant professor in AIMS Jodhpur, and our dear colleague, my respected mentor, Dr. Lalit Mohan Sharma sir, SRC MGA Jaipur. Aditi Thanke, consultant medical oncologist in Sterling Hospital, Rajkot. Dr. Suparna Rao, PD Hinduja Hospital in Mumbai, and Dr. Rishabh Jain. He's a consultant medical oncologist, RHL, Renova, Jaipur. So we'll discuss one trial only, and I will share the again it will echo. So briefly,
sorry. Hello. ललित सर, आपने नियर बाई डिवाइस को दो डिवाइस से ज्वाइन किया? दोबारा बोलिए. आपने दो किया है नियर बाई से? नहीं, डिवाइस एक ही है मेरे पास, दो से नहीं किया, एक से किया हुआ. क्योंकि आपकी से साउंड इको हो रहा है. मैं मेरा म्यूट करता हूं तो देखो, दोबारा कंफर्म करो. नाउ आई एम म्यूटिंग. या नाउ इट्स परफेक्टली फाइन. कैन यू अनम्यूट?
Okay.
Is it echoing now also? अभी मैंने still echo, sir. Can you rejoin?
Yes, Dr. Pramod.
Yes, sir. Yes, sir. Hello.
The sound, sir. So we'll touch upon this trial, Proteus trial, which is a very important trial, and this is here only presented in the ESCO 2026. So very less known about the adjuvant or neoadjuvant therapy in the prostate cancer. But these two trials, one was the Stampede trial and one is this Proteus trial, which has brought something very new and exciting in the field of the prostate cancer, where you can use as a other solid tumor like breast and ovarian other tumors neoadjuvant therapy. So neoadjuvant therapy we give with the intent of getting more pathological CR, and maybe they can be converted in the distant recurrence free survival or metastasis free survival. So this particular concept was tested in this Proteus trial. Has Lalit Mohan sir joined, sir? Sir, without you we cannot progress actually. Begin, sir. We will take your response by yes and no. Even if you are muted. Okay. So this Proteus trial was done for having this neoadjuvant therapy. So they have given. My voice is clear, sir. Pramod?
Yes, sir. Yes, sir.
Okay, then that's fine. Okay, so 1 year perioperative, the therapy was devised to get the more pathological CR. Earlier, we used to give ADT as we give in the pre-RT sessions, but now in the surgery also, which we need to teach the urologist that we need to give some therapy before or prior to the surgery. So earlier it was ADT in the high-risk prostate cancer, but now they have tried this apalutamide for neoadjuvant therapy, and they have given the sandwich type adjuvant therapy also. And they got this particular situation like where high risk cancers are there. They have actually did the 10 times of the pathological CR. They got the 10 times pathological CR, and there is a significant improvement in the metastasis free survival. So this was the crux of this trial. So now we will start the question and all that.
So this was the basic trial design of the Proteus trial. So they have taken the high-risk prostate cancer, locally advanced prostate cancer, and for the they have randomized 1:1 patient. So the control arm was placebo plus ADT, which was the standard arm until this trial has designed. And then the experimental arm, they have given ADT plus apalutamide for 6 months. And then they have given the 2 weeks of drug-free interval to the apalutamide arm, and then the standard surgery was done. That was the radical prostatectomy, and then 4 weeks of the drug-free apalutamide-free interval, and then they have given apalutamide for the 6 months. Okay, and they have did the PSMA PET before, just before the surgery, and baseline, and after the surgery. So this was a basic design for the this Proteus trial. So they have defined PET-CR as a YPT0, and there is some downstaging also. And the MFS term was device metastasis-free survival. That is, metastasis should be free by the PSMA PET imaging. Okay, and then we have done the everything. So there were no major side effect happened with the apalutamide, and you can see the apalutamide plus ADT versus placebo plus ADT. The PHCR rate was 30.6% versus the 11.7. Just you can say the with the ADT it was just threefold increased, and the overall response rate was overall survival. No, it is hazard ratio for this PHCR rate was 0.0001. So this was the primary endpoint, and so they have achieved both the co-primary endpoint, PHCR rate and the MFS, which was significant. So we can see in this curve, dual primary endpoint, MFS by conventional or PSMA PET scanning, which is standard of care. So there is 20% reduction in the risk of metastasis or death after 1 year for perioperative apalutamide plus ADT and the with the radical prostatectomy by the BICR. So now we will move to the question answer session. So I will just skip the slides in between. Okay, so this was the publication in the New England Journal this year only. So yes, the question I will ask to Dr. Pramod first. What do you feel about the Proteus trial? Do you feel like it is a practice changing, or you can convince the uro-oncologist or urologist for giving this kind of drug? Dr. Pramod.
Good evening to all. Yes, this Proteus trial is a very interesting trial, and it has given us scope for medical oncologists in a curative prostate cancer settings. Usually, we get a metastatic prostate cancer, and largely by post 2 or 3 lines. This trial is addressed to one question, that the high risk and very high risk prostate cancers.
Yes.
So they are high risk and very high risk prostate cancer. They are the worst locally advanced or localized prostate cancer, and they have a very high Gleason score, or the PSA is more than 20 or 40, and it's T3 T4 disease, and they are seldom a direct candidate for surgery. So they are the candidate for largely they are the candidate for CTRT, for radiation therapy. But by downstaging this tumor, we can first of all we can improve the survival. Second, we can avoid a transformation from castration sensitive to castration resistance in this setting. So this is important, that if we are getting good PET, so we are avoiding a disease to progress, and also avoiding a biological change from castration sensitive to castration resistance.
Very well said. Yes, Lalit sir wants to ask something.
Yeah, see, in fact, in addition to whatever has been said by Dr. Pramod, it looks that at our settings, most patients do present with locally advanced disease. Many times they are presenting with metastatic, but now with increasing awareness, we are able to see the locally advanced disease also. And once they go to urologist, they are tempted to perform the surgery as fast as possible. So, in fact, if they do a surgery in an inflamed tumor, that happens usually after doing even biopsy also. So it is said that after biopsy, 3 to 6 weeks gap should be there, but surgeons many times are prompted to do early. Second thing, there is increasing use of robot surgeries also in Rajasthan also and everywhere. Third thing, more and more like these patients, close to 50% of these patients, they do relapse within 5 years. So either locally or somewhere else. So this becomes a tough area. So the neoadjuvant therapy is definitely going to make some difference. Of course, we need to convince our neurologists so that they are confident in sending to us. Yet, even at my centers, urologists, they are afraid to send the patient to us. They do upfront surgery and then they refer to us. So very true.
That is very point well taken, sir. Actually, we are afraid of the urologist that kind of the patient they are operating, when they want to operate upfront, as if the patient will never touch them. And the thing is, they are giving all the hopes because of the robots. So they say like by the robot they will clear everything and the patient will be all right, and hopefully he will not reoccur. But the thing is, only 30% patient in the locally advanced setting they can be cured and the survival is more than 5 years. Within 5 years they will recur. So this is the particular area where we need to concentrate, and we need to educate our urologist also. So this is the simultaneous teaching to them also. We can have a seminar and we can invite in our meetings and all that, so they can be sensitized. And after sensitization, we can sensitize the population at risk, like cancer patient, that if we give this kind of the neoadjuvant therapy, then your survival will be better. So then if the tumor board situation is there in the institute, then they should be abide by the rules of the tumor board, and we can sensitize our population also. So I will move to Dr. Aditi. Dr. Aditi, can I see you there?
Yes, yes. Good evening.
Yeah, Dr. Aditi, good evening. So what do you feel, it is practice changing in your institute, or you can convince your urologist, or it will take some time or some years? What is there?
I feel it will take some time, definitely. For Rajkot, majority of our patients are not upfront. They are sent after surgery from a urologist. That is how the referrals are done. But we can definitely, as you highlighted, sensitize them that for surgical candidates, we have role of offering them neoadjuvant treatment in prostate cancer as well, which was never thought previously. So we are not taking away, we are not discussing it to be compared with radiation protocol, but for pure those patients who are choosing surgery, they can definitely get benefit with addition of perioperative ADT with apalutamide in terms of metastasis-free survival, and that is a very key endpoint for this locally advanced high risk or very high risk patients.
But Aditi, we feel and we heard a lot of about the Ahmedabad and Gujarati surgeons, and particularly the Nadiad area. They are very aggressive in operating the person in the urology sector. So do you feel like they will heard your voice?
So we'll need some time to convince them. The data is encouraging. They can ask about long-term data, obviously, because that is not something which we have as of now for for long-term survival benefits. But whatever we have is quite encouraging for giving an additional benefit to the surgical population only.
Yeah, so one very good plea which they give, the urologists give, that their suppose PSA is 200 now at the baseline, and you give this effective therapy, apalutamide and ADT, then PSA will be go down, or maybe it is 0. Then what happen if patient will not turn up to you and me? You and me means the urologist and the medical oncologist, and they will rest at home. So what will happen to them? So they give the plea like, why not we should operate them?
Sir, this is a real challenge actually in a breast cancer also. The patient who have PATS, yeah, there is a high default rate. They found no breast lump, and they say, why should I go under any mutilating surgery?
In the breast cancer, what happens is that they don't feel like they are in the CR. But in the prostate cancer, they see the PSA report, so they feel like everything has been cured. It is a basic problem.
Yes, sir.
So I will move to Dr. Suparna Rao. Is she there? Dr. Suparna?
Hello, Dr.
Hi, Dr. Suparna. So the question is same to you.
like follow-up conditions, how you will deal with. Like suppose your urologist said like if the loss to follow-up happens, then you will be the responsible person.
I think it's obviously making, patient understand that just like how in CO ovary you give NACT, it doesn't mean you can't do, can't be without surgery. It's about explaining to them, keeping them also part of the
Exactly. Yeah.
discussion.
Exactly.
And make it multidisciplinary. So I'm thankfully in a setup where we have a uro-oncologist who's very up to date, himself, and urologists are usually on board with what we decide. So of course it will take time. We'll have to sensitize them about this data. But I think especially for a high risk where even MFS makes a lot of sense in terms of improving probably subsequently their survival. I think it's of course important to involve everyone and also tell the patient that it doesn't mean you are likely to be lost to follow-up, which means they are not going to continue subsequent apalutamide and ADT also. They are invariably going to recur at some point. So this is something we will have to sensitize, I think, upfront and tell them that this is the plan. It will take a while, I think, for patients also to come around because people are not comfortable knowing that there is a probably operable cancer and you're still not operating, you're waiting for 6 months. But it's something, motivating surgeons and patients, I think, is going to take a while.
And I guess the good coordinators and the tumor board coordinators will help us to call them to follow up telephonically. They will be in the confidence. And the other plea which I give to my urologist is if we give this preoperative therapy and if the patient will be disease free for 5 years, then all credit will goes to you. So please be sensitized with this and you give the better chance for survival or metastasis free survival to the patient, and the majorly credit goes to the surgeon only. So you will be at the gainer end. So they are actually in the you can say consensus of giving the neoadjuvant therapy. So we can give this plea to them also. Lalit sir, you want to ask something, or you can highlight?
Just wanted to tell you that at our center with difficulties, we are able to convince urologists for neoadjuvant therapy in urinary bladder cancers. So now we are getting most patients that referred for neoadjuvant chemotherapy, and they are attending the tumor boards also, and with time, like they are getting sensitized. So I'm sure that with time we will be able to convince them for prostate as well.
Okay, sir. So these are the real questions, and Dr. Suparna Rao highlighted the very good thing is if they are ready to take the neoadjuvant therapy, they might take the adjuvant therapy also, and the survival will increase. So I guess your oncologist, Dr. Hemant Tongaonkar, Suparna Rao.
Dr. Tongaonkar was there earlier. Now we have Dr. Ganesh Bakshi.
Okay. So he's from Tata, so I guess.
Yeah. So he in fact will tell us that this is the update.
But
he is
must
very
insist
pro
you.
Multidisciplinary.
Yeah, he
no,
must be
he
insisting.
will. I don't see resistance from his end at least.
No, he must be insisting you to please give the neoadjuvant therapy so that
Yeah,
our result
yes.
can improve.
Definitely. And he is that
Yes,
way
yes.
very firm with patients. So I think patients understand too.
Yeah,
we
yeah,
have
exactly.
motivated patients too. Yeah.
Yeah, now from Tata we move to the AMS. So I will call Dr. Rishabh Jain. Dr. Rishabh. Support him. Dr. Rishabh is there.
Hi, sir. So, sir, what I
Hi.
feel is this trial design is one which will angry both the radiotherapist and the urologist at the same time. Because from the radiotherapist, we are taking away the high-risk disease, and for the urologist, we are creating a dilemma. As we can see in the design of the trial, in the placebo arm, they have taken the neoadjuvant ADT, and it's not like upfront surgery. So, if we have to interpret the results for the urologist, we don't have a way to interpret, okay, if you do the surgery first, then the ADT, or the neoadjuvant apalutamide plus ADT. What is the difference?
No, so the ADT nowadays it is standard of practice, like we give ADT and send the patient for high risk surgery. Otherwise, they also have a difficulty to operate them. If the T3 lesion is there, their seminal vesicle is involved, then they are also in the trouble to operate. So capsular venous plexus is there, and they are very in the tough situation to operate. So they want also to give ADT. Okay, so my question to you, Dr. Rishabh, is we have improved PCR and MRD or MFS. So which endpoint is which you like for the localized prostate cancer? It is MFS or it is PET-CR rate?
Sir, MFS definitely, because PET-CR rate does not have a very good like data for prostate cancer per se. It might have for breast, but not for prostate. And MFS, the metastasis are
Prostate,
the
prostate, it was 3% with the ADT. So who will know about this? So now the trial has come, so at least we are discussing that.
yes, sir, but we don't know how it correlates with DFS or OS yet. So that's why MFS would be a very good indicator, because most of the morbidities a prostate patient might have would be because of pain due to the metastasis. And MFS, hence, it would be a very good criteria to see.
Yeah, so you mean to say like patient will be saved from the metastasis, so it is good.
Yeah.
Yeah, that is true. So the classical data says like if patient has been metastasized, so their survival is less than 5 years, and if they are CRPC, then it is less than 2 years. So we need to save them from the metastasis, and if metastasis already happened, then we need to save them from the castration-resistant prostate cancer. That is there. Dalit sir, if your voice is not echoing, I would like to your input also.
Yeah, in fact, in like previous discussion that the urologist, they are scared. So in locally advanced disease, they are already using ADT. So most
Yes,
of
yes.
the urologists
They give themselves, but they are using.
Yes, they are using. So with addition of another androgen receptor inhibitor will be a good option. In fact, so I think the convincing power by medical oncologists need not to be too heavy. They will be able to convince.
They can give apalutamide also, sir.
Just one point can I highlight?
Yes.
Yes, yes.
So
Why
the
not?
PATH-CR that they defined was not actually pathological CR, because even T1 was included in that.
Nobody listen your voice. Actually, your voice was echoing. Okay, we'll move.
Sir, sorry to interrupt you. Sir, please conclude the session in next 2 minutes.
Okay. So this is a burning question is, I would like to ask Dr. Aditi. So what do you feel, which type of the patient in real world scenario is suitable for the Proteus trial? Dr. Aditi?
I would say for those patients who are keen on surgery, these are surgical candidates with a high or very high risk. That would be at least T3, T4. And just to highlight that these patients had Gleason score of, matlab Gleason's group of 4 to 5, at least in 6 of the 12 quadrant biopsies in the Proteus study. So they were not in 1 or 2 biopsies. That way, it was a high burden Gleason group as well, with PSA more than 40, and the patient is motivated to undergo surgery. Those were the set where we would like to give them perioperative ADT with apalutamide.
So I mean to ask you, like, if you have like 10 patients in your OPD which are operable, so how many of them will go for this trial?
So right now, if the patients are coming to me, I would definitely advise them for perioperative apalutamide with ADT. But as we discussed previously, it will be difficult for the surgeons to get convinced upfront with the said reasons already we discussed. Probably 1 as of now out of 10.
Yeah, maybe. So we need to increase the percentage of population which we can give the neoadjuvant therapy. And for surgeon, we will ask them to, they will be in your follow-up also. So every time they will come to us, they might see you also for their confidence. So, and the last question to Dr. Suparna. Dr. Suparna Rao.
Yes, sir.
What do you feel which is the ideal population to your hospital, which you can subject for the neoadjuvant therapy by medical oncologist?
I think similarly, I mean, in our hospital, usually this goes to the urologist or the uro-oncologist. I think I can hardly remember 1 or 2 patients who came, to me because they were referred through somebody else who I had treated. Otherwise, invariably, these patients go to urologists and uro-oncologists. But I think uro-oncology is here, since we give ADT to at least higher risk patients, especially seminal vesicle invasion, higher PSA, I think they will also be okay to give. I mean, honestly, urologists and uro-oncologists have been giving hormonal therapy to patients. So I think it's about sensitizing
For
them.
that
I don't know how
matter,
many will
this
come to
Abiraterone
me.
also they give.
Yeah, so they give abiraterone and enzalutamide, and once there's progression, they send to us for systemic therapy, honestly, like chemotherapies in metastatic CRPC settings. So here, I wouldn't be surprised if they themselves, decide to go ahead and treat with apalutamide and ADT. But I think we have doctors who would be motivated enough to give it. I mean, if they're giving ADT and waiting for, say, 2 to 3 months to operate, I'm sure they'll be okay giving apalutamide and ADT for 6 months. That is around 2 doses before they decide on surgery.
So, and at least you can bargain that once you do the surgery after 6 months, you please send for the adjuvant therapy.
That I don't know if I'll be able to bargain, but as long as patients receive it, I think that's okay. I mean, it would depend on patient to patient. Patient with comorbidities, I think, would come to us. Patient who are fairly, well fit, I think they would end up getting treated. So I think that's how it works in general. Most uro-oncologists or urologists tend to give the hormonal. So I would be, surprised if they send as a dictum to us to give systemic
Sometimes,
therapies for
Suparna,
all
you
patients.
might, yeah, sorry. So sometimes you might think like the drugs which have greater side effects are better for medical oncologists because then nobody else will touch for
Yeah,
this
they
kind of
don't.
drugs.
They don't look for side effects. And then patients have uncontrolled sugars, they have dyselectrolytemias, and then we send it,
Sir,
we
request you
suddenly
to
send
conclude
this.
your
Yeah. So we'll conclude this session. This was a very interesting trial, and we need to implement in our MDTs and tumor boards, and we will sensitize our urologists, and whatever bargain they want to do with us, will ensure that the patient will come to you for surgery. So please let us give the neoadjuvant therapy, and if not neoadjuvant, then give us chance to give the adjuvant therapy so that patient survival can improve and PCR rate can improve. Thank you very much for giving me the chance. Thank you, Dr. Ankit Agrawal and the team of Horizon. Thank you.
Thank you.
Thank you. Thank you. Wonderful discussion, sir. Thank you.
Now we move on to our next talk. I would like to invite Dr. Abhishek Bansal, consultant medical oncologist, Fortis Escorts Hospital, Faridabad, and Bansal Nursing Home, Palwal. Over to you, sir. And this is a sponsored session by Estelas.
Yeah, thank you for the invite. Can you put on my slides, please?
Yes.
So, topic for today is redefining outcomes in bladder cancer, evaluation of enfortumab in first-line locally advanced metastatic urothelial cancer. Next slide, please. These are my disclaimers and brought by Estelas. Next slide. So, coming to the trial of using this therapy, enfortumab with pembrolizumab versus chemotherapy in advanced untreated locally advanced or metastatic urothelial cancer. Next slide, please. EV302 design patient population previously untreated locally advanced metastatic urothelial cancer eligible for platinum and 45 and PD-L1 inhibitor. Basically, GFR more than 30 PS of less than 2 were combined with enfortumab and pembrolizumab for EV. No maximum treatment cycles for EV. Maximum cycles for pembrolizumab was 35 cycles compared with the chemotherapy standard with gemcitabine and carboplatin or cisplatin. And treatment was given until disease progression, and dual primary endpoint was PFS, OS, secondary endpoints for overall response rates and stratification factors for cisplatin eligibility, PD-L1 expression, liver mets, and so the first, these were the key demographic and baseline disease characteristics. Next slide, please. 32% and enfortumab and pembrolizumab remain on treatment at time of analysis. Next slide, please. So you can see the PFS and PFS risk of death was reduced by 55% who received enfortumab and pembrolizumab arm. Hazard ratio was 0.45 and median PFS was 12.5 months versus 6.3 months. Next slide, please. Subgroup analysis of PFS. It favors the enfortumab and pembrolizumab arm, and subgroup analysis showed that this was the benefit of this drug in all the subgroups. Next slide, please. Risk of death was reduced by 53% in patients who received enfortumab plus pembrolizumab. So hazard ratio was 0.47 and median OS was 31.5 versus 16.1 months, and median survival follow-up was 17.2 months. Next slide, please. Subgroup analysis sustained benefit of enfortumab plus pembrolizumab across subgroups after longer term follow-up. It could be seen in cisplatin eligible, cisplatin ineligible, and you can see in both the both the tables, the enfortumab plus pembrolizumab was the clear winner. Hazard ratio was 0.54 and median OS was 25.6 versus 12.7, and median OS was 36.7 versus 16.7 months, and presence of liver mets clearly showed that median OS was 19.1 months versus 10.1 months. Hazard ratio was 0.566. Next slide, please. So OS benefit was consistent across the overall population, regardless of the PDL1 score, and more even in high or the low. Next slide, please. So Pan-Asian subgroup long-term follow-up, the PFS on the Pan-Asian and OS subgroup, the enfortumab plus pembrolizumab hazard ratio was 0.367 and OS was 0.326. Next slide, please. So exploratory analysis in older patients, PFS was combination chemotherapy was 0.426 and OS was 0.5, suggesting the benefit of this combination and therapy. In older subgroups also. Next slide, please. So efficacy data in evaluated subgroups were consistent, and the OS benefit in patients with diabetes or PFS in patients with diabetes combination chemotherapy was the clear benefit in patients with diabetes. PFS and versus chemotherapy were maintained across patients with diabetes. The combination of enfortumab and pembrolizumab. The subgroup analysis of OS clearly favored shifted to the left, suggesting the benefit of this regimen, and OS was significant in patients with GFR less than 60 also. This combination was preferred. Next slide, please. So in selected predefined subgroups, depending on PDL1 status, liver mets, which we discussed earlier, cisplatin eligibility, all favored the combination approach. Next slide, please. So our overall response rate was 67.7%, and median duration of response was not reached versus 7 months, and significant improvement in objective response rates was observed. Next slide, please. Duration of response among responders, the probability of maintaining response at 24 months was 50% with combination therapy versus 24% with chemotherapy. Next slide, please. Duration of response by independent response in responders by cisplatin eligibility. The combination therapy was 24.4 versus 8.3 months, and it was in cisplatin ineligible, it was 21.9 months versus 6.6 months. It all favored the combination therapy versus chemotherapy, irrespective of cisplatin eligibility. OS in all patients with CR plus PR, median OS was 39.3 versus 32.1. Hazard ratio was 0.59. Time to response and conversion from PR to CR, median time to objective response was 2.1 with combination therapy and chemotherapy. Median time to CR was 4.3 months. In the median time to objective response was similar in the combination EV plus PV and chemotherapy arm, most patients with CR achieved PR before converting to CR. Next slide, please. Duration of response by independent review patient achieving CR. The probability of maintained CR 2 years after the first documentation of CR was 74.3% with combination therapy and 43.2% with chemotherapy. Next slide, please. OS in patient achieving CR. The median OS was not reached and chemotherapy also was not reached. Stratified hazard ratio was 0.37. Next slide, please. Summary of subsequent systemic therapy. 59% of patients with chemotherapy arm received subsequent PD-L1 inhibitors. Next slide, please. Treatment-related adverse event, median number of cycles. Grade 3 events were more in chemotherapy arm versus the combination arm. Next slide, please. With additional 1 year of follow-up, EV plus safety profile remained consistent. No new safety profiles were consistent. And next slide, please. Bridging trial to real practice, EV plus pembrolizumab showed a more safety profile. Limited EV plus pembrolizumab experience currently exists in real-world clinical settings. Real-world patient consideration offer more valuable compared to those enrolled in clinical trials. Older age, higher burden of comorbidities, impaired renal and hepatic function. This emphasizes the importance of careful monitoring and education for early symptom recognition, careful adverse event mitigation strategy. Key adverse events were skin reactions, early onset, peripheral neuropathy, cumulative pneumonitis, ILD, and hyperglycemia metabolic, mainly related to the EV arm. Next slide, please. So these are the treatment of adverse events, which like skin reactions and the severe skin reactions. Next slide, please. The median time to onset of selective adverse event EV monotherapy, hyperglycemia 0.5 months, severe skin reaction 0.6 months, symptomatous ocular disorder 1.7 months, pneumonitis ILD 2.9 months, grade 2 peripheral neuropathy 4.9 months. And the EV plus combination therapy severe skin reaction was at 1.7 months, and pneumonitis ILD was at 4 months, and grade 2 peripheral neuropathy was at 6 months. Next slide, please. So these are the current treatment paradigm in which the combination therapy is approved as the first line as per the ESMO guidelines, and if disease progression, then we can give the combination of chemotherapy. Basically, if the EVM pembrolizumab is not available or contraindicated, then we can, in cisplatin eligible, we can use the combination chemotherapy with nivolumab, and disease progression, then we can use single agent enfortumab or erdafitinib FGFR inhibitor. And cisplatin eligible or ineligible, then if it's with chemotherapy, then disease progression is there, then we can use the basically immunotherapy like pembrolizumab or atezolizumab, or we can switch to enfortumab. And if no disease progression, then the maintenance avelumab. If disease progression is there, again switch to enfortumab. So this, I think, is the same which I've covered. Thank you.
Thank you, Dr. Abhishek. I think we need more time to incorporate enfortumab vedotin, especially I think for the patients in a routine clinical practice, considering the cost. I think otherwise it's an amazing data, and we would love to use it for our patients routinely if affordable.
Thank you, sir. Thank you, Dr. Abhishek. Moving forward for the last session, which is sponsored by Glenmark, I would like to invite Dr. Rohit Swami, consultant medical oncologist, Narayana Multi-Speciality Hospital, Jaipur, for his talk on personalizing CINV pyrophylaxis lessons from my risk trial. Over to you, sir.
Yeah, good evening, everyone. Please share my slides. Good evening, everyone, and thank you, Dr. Ankit Agarwal, for giving me this opportunity. And also sorry for any inconveniences caused by me because of previous absence in the previous
Alright, please, okay, it's okay, sir. We understand, we
session.
understand. We totally understand. No issues, sir. Please.
Yeah, yeah. So I'll be discussing how to personalize CINB profile access in patient receiving chemotherapy as per MyRisk trial. Next slide, please. So as we all know that we have divided the patients who are receiving chemotherapy in four risk group: high risk, moderate, lower risk, and minimal risk. And these patients are receiving CINV prophylaxis as per the guidelines. But there is no incorporation of personalized factors or individual risk factors which increases the risk of the patients. And there is no such arrangement in any of the guideline that individual factor can increase the risk of the patient of from moderate to high risk or from minimal to moderate risk. So these risk factors are considered important in various guidelines, but never incorporated in algorithm to calculate the risk of patient having CINV. Next slide, please. So CINV prophylaxis started from 1991, where it was only symptomatic treatment of having the chemotherapy-induced CINV, post-chemotherapy, giving antiemetic therapies, up to the recent 2026, where now we have pre-chemotherapy medications and effective medications which decreases the risk of CIMV from 40% still to up to 5 to 10%. So MASCC was the first organization which was made throughout the world, named as Multinational Association of Supportive Care in Cancer, which gave us an algorithm to how to calculate the risk of having grade 2 or more than grade 2 CINV in cancer patient receiving chemotherapy. So as we can see in this slide that there is this table which includes 8 main risk factors which increases. These are individualized risk factor which can increase the risk of having CINV post chemotherapy from minimal to moderate or moderate to severe. And the main risk factors are age less than 60 years or patient having sleep less than 7 years, minimal alcohol use, having platinum or AC induced chemotherapy, having morning or motion sickness, or patient already on prescribed antiemetics, or patient had nausea or vomiting in prior cycles. So this table makes a score, and if the score is more than 16, then having the risk of grade 2 or more than grade 2 CINV during the even giving the moderate hematogenic potential is considered as a high risk hematogenic patient. Next cycle, please. So these patients were gradually divided into a high risk of having grade 2 or more than grade 2 hematogenic potential to moderate, low, and minimal. But the thing with this scoring system is that majority of the patient, around 60% of patient, comes in the moderate risk. So it was by widely accepted model. It was easy to apply in clinical practice. But the thing is that 60% of patients have to wear the same shoe of the same size. All of them have to receive the same antiemetic regimen instead of their individual risk factors, whether they are having high uh, individual risk factors of having hematogenesis or low risk factors. So next slide, please. Next slide. So MSCC guideline says that high risk patients having non-AC regimen or AC regimen should receive all the four prophylaxis of 5-HT3 antagonist, dexamethasone, NK1 antagonist, and olanzapine. Moderate risk having carboplatin AUC more than 5 or oxaliplatin in women less than 50 years should receive NK1 receptor. But other moderate risk patients shouldn't receive NK1 receptor. They have to receive only 5-HT3 antagonist and dexamethasone. And low one, any of these. Minimal, no routine prophylaxis. Next slide, please. So basically, these chemotherapy-induced nausea vomiting prevention in antiemetic guidelines has been different, and there was no consensus in different guidelines till 2025. NCCN says that individual risk factor which increases or give additional risk in having CINV are enlisted as following, but these risk factors were never included in the algorithm to personalize the CI/NB prophylaxis in each and every person. Similarly, MSCC and ESCO also gave the individualized risk factors as we can see in this slide. Next slide, please. So this phase 4 study came, which was considered as a MyRisk trial, which was aimed to individualize this CI/NB prophylaxis in each and every patient receiving chemotherapy regimens. Next slide, please. So study schema was very simple: chemotherapy, hematogenicity potential, plus patient-related risk factor, and the output is patient at high risk or low risk. So patient-related factors for patient self-medication or patient is less than 60 year, antisymmetry, nausea, vomiting, history of morning sickness, CI/NB in prior cycle, reduced sleep night, prior chemotherapy, use of platinum or anthracycline, or first 2 cycles of chemotherapy with vomiting. Next slide, please. So background of this study is that they compared NEPA plus DEXA versus any of the 5-HT3 antagonists plus DEXA across the 3 cycles of moderate hematogenic chemotherapy, and to see whether there is complete response or there is partial response. So complete response was considered that there is no incidence of nausea or vomiting in the acute phase as well as delayed phase. So algorithm was more or less taken from the MASCC guideline only, and here high risk CI/NB risk score was reduced to 13 only. 13 or more than 13 were considered as high risk CI/NB category. So all of these factors were similar as the MASCC guidelines. Next slide, please. So why to consider NEPA as compared to aprepitant or fosaprepitant? So as it has been seen in the previous studies that the NEPA has unique pharmacological profile. It has longer half-life and higher receptor occupancy in the brain, and significantly better CNV control compared to other NK1 receptor antagonists. As we can see in the graph, that actually aprepitant or fosaprepitant has a better NK1 receptor occupation as well as better plasma concentration, but it fades very quickly as compared to nucleopitant, which has a consistent plasma concentration as well as consistent NK1 receptor antagonist action. Next slide, please. And this MyRisk study design, as told earlier, was a phase 4 interventional study. It was multinational and open label randomized study, was further sub-stratified as per carboplatin use versus no use or the country where it was received. So the schema was simple: patient receiving moderate hematogenic potential chemotherapy, then patient risk factor, and then the patient who were considered as a high risk MEC patient, high risk patient who were receiving moderate hematogenic potential chemotherapy, to be randomized in 1:1 fashion to NEPA plus DEXA or any 5-HT3RA plus DEXA. Primary endpoint was complete response, that is in the overall phase, that is up to the 5 days from receiving the chemotherapy across 3 consecutive cycles of MEC potential. And secondary endpoints were during the acute phase, delayed phase, or overall phase: complete response, complete protection, no MSS, no nausea, no rescue medication, quality of life index, and safety. Next slide, please. Next slide. So if we see patient demographic, baseline patient demographics were well balanced in both the arms of this study, and most of the patients were around 62-year-old age. 50% male and female were there. Most of the patients were ECOG 0 and 1, and chemotherapy naive patients were more, 75% as compared to 25% of patients who had previously received chemotherapy. Most common cancer type, as we all know, the commonest cancers were included. 64% received oxaliplatin, 30% around received carboplatin, and 6% received other moderate hematogenic potential chemotherapies. Next slide, please. So coming to primary endpoint, complete response across all the 3 cycles of MEC. So overall phase, there was significant complete response in NEPA plus DEXA as compared to any other 5-HT3 antagonist plus DEXA. So it was 81% probability of having complete response as compared to 71% with a significant p-value. Next slide, please. Coming to secondary endpoint, complete response across 3 cycles during acute and delayed phase. So in the acute phase, there was no difference in NEPA as compared to other 5-HT3 antagonists. There was similar response in the acute phase, but in the delayed phase, uh, from the day 1 to day 5, there was significant complete response maintained by NEPA as compared to aprepitant or other 5-HT3 antagonist plus DEXA. So basically, as we had already seen that aprepitant or phosphaprepitant has initial very high concentration and it fades very quickly. Half-life is very short. Next slide, please. Coming to secondary endpoints, no nausea rates by cycle. So no nausea rates were consistently higher with NEPA in delayed and overall phase in each chemotherapy cycle. Next slide, please. Efficacy in moderately emetogenic chemotherapy receiving patients for whom SCC or ESMO does not recommend NK1RA. So subgroup analysis was done. So the patients who are not recommended NK1 receptor antagonist by the MSACC guideline or ESMO guideline, in the acute phase, there was similar response, but in the delayed phase or overall phase, there was significantly reduced emetogenesis after chemotherapy with NEPA plus DEXA as compared to any other combination. Next slide, please. And coming to quality of life index, so definitely when there is no nausea, no vomiting, there is complete response. So quality of life index was well maintained with NEPA as compared to other 5-HT3 antagonists or other combinations. Next slide, please. Coming to overall summary of events, so definitely incidents of treatment-related adverse event were seen in both the arms, and there was toxicity, safety profile of NEPA and standard of care arms were comparable. There was no significant difference observed in adverse event profiles. Next slide, please. So conclusion is that NEPA plus DEXA was superior in having complete response in chemotherapy-induced nausea vomiting from a moderately emetogenic chemotherapy in patient with elevated CINB risk. So superiority were consistently observed across several secondary efficacy points, including no nausea, most challenging symptom to control, and it was consistent with overall MyRisk trial results that NEPA demonstrated better CINB prevention as compared to any other combination for CINB prophylaxis. Next slide, please. So clinical implication of this trial was that if there is moderately emetogenic potential chemotherapy or high risk, you have to go with NEPA and DEXA. If there is moderately emetogenic potential, then consider the personalized risk factors to uh, uh, segregate the patient in moderate or high risk and go ahead with NEPA if the personalized risk factors also add up and make the patients high risk for emetogenesis post chemotherapy. Next slide. Thank you. Thank you for patiently listening.
Thank you, sir. Thank you for your excellent presentation. So now I would like to invite Dr. Ankit Agarwal for the final and closing remarks. Over to you, sir.
Thank you, Dr. Rohit. Thanks a lot. That was amazing and very crisp and also you highlighted the points very beautifully. I think we have come to the end of our today's session on the webinar, and I would like to thank all my colleagues, all the moderators, panelists, and all the speakers for having a wonderful discussion. I would special thanks to our academic partners who made this possible, and the tech team from Horizon. I think it was a wonderful today discussion. Looking forward to more discussions like this and involving you guys, and please involve me in your future discussions also. So thank you once again, and have a good night, and see you soon again.
Thank you, sir. Thank you, everyone, for joining. Thanks to our academic partner. Thanks to the technical team. Thanks to Daud, Manya, and Pooja, who has put a lot of efforts. Thank you, everyone. Good night, everyone, till we meet again. Thank you, sir.
Good night, everyone.
Good night. Thank
Good
you.
night. Good night. Support team, close the meeting.
Okay, ma'am, we are ending the meeting now.
Sure.